about mechanistic approach of nanolipid vesicle for targeted delivery, mainly cancer chemotherapy, breast cancer chemotherapy I'll discuss today. Actually, cancer cell is the abnormal cell proliferation within the uncontrollable, actually abnormal cell proliferation without any means due to some carcinogenic or disturbance of oncogene or proto-oncogene. That is that the more cancer patients are suffering some unwanted effect during cancer chemotherapy. Our main objective is the passive targeting for cancer cells, and by the passive targeting as well as some active targeting also, because the so nanoliposomes or nanolipid mainly are the for passive targeting, or some cancer cells or malignant cells are the abnormal cells from other than the normal cell, because basement membrane is leaky, so that nanoparticle or liposomal or so many carbon nanotubes or quantum dots or spherical nanoparticles or micelles is there. They are easily entrapped in the leaky vasculature and enhance permeability and retention effect, so that the passive targeting is possible for cancer chemotherapy. And sometimes cancer cell is travel in the other body parts of human body, that is known as metastasize also. And for that portion, nanoparticle or anti-cancer cannot recognize. That is the patients suffering from so many side effects, nausea, vomiting, alopecia, and other several. For the prevention of the unwanted effect, active targeting, so that anti-cancer drug can recognize the malignant and neoplastic cell, and increase the long circulation by polyethylene glycol cell, that is known as silk liposome also. And other than this, the enzyme are polymeric nanoparticle hydrogel also there. And our main objective is the here we have showed some next slide. Can you please turn? That this leaky tumor vasculature is there. Previously I have told that is the two target of action we are approaching here. That is the targeting ligand or so many phosphoethanolamine linker molecule by tagging or conjugation of the surface of the nanoliposome or nanoparticle, other nanoformulation, so that it recognize the cancer cells also. And cancer cell, I have told that is the neovascularization, means angiogenesis is going on in neovascularization, so that some angiogenetic inhibitor, trastuzumab or other, then we have attached the linker molecule in the surface of the nanoformulation, so that neovascularization can prevention and malignant cells can be destroyed and cannot survive in future. This is the more targeting approach for the cancer chemotherapy during treatment of the cancer patient. And non-targeted vesicle for passive targeting, we can approach here also by the entrapment or increase the cellular uptake or cellular endocytosis in the cancer. We have shown next the some cellular endocytosis or cancer cell. Please next slide. You can please turn the next slide. This is the some passive targeting, active targeting, and enhanced permeability retention effect I have shown here for ligand molecule attaching in the surface of the outer surface of the nanoformulation, so that easily entrapment to the endothelial cells and to IV infusion, and can improve for the during chemotherapy. Please next slide. Now I'll tell some liposomal next slide, nanoliposomal preparation. Here I have applied thin film hydration method, tamoxifen citrate or sometimes doxorubicin or dactinomycin, some anti-cancer drug, we have loaded in the dissolved in chloroform in round bottom plus 250 or 500 ml capacity with cholesterol also elicited. Because this type of drug is hydrophobic in nature, the first day, 4 consecutive days I have is required for the non-nanoliposomal preparation here for thin film hydration method. The anti-cancer drug cholesterol and lecithin we dissolve in the organic solvent, that is chloroform, and with vigorous taking in we kept in rotary evaporator. We have applied PBU6 here. After 5 to 10 minutes, totally organic solvent evaporator and thin film was formed in the inner layer of the round bottom flask. And for after that preparation, we kept in the dark place for overnight for the complete evaporation of organic solvent and formation of the thin film interior wall of the round bottom flask. Next day, second days, with phosphate buffer saline pH 7.450 ml or more 100 ml capacity 100 ml have poured in the round bottom flask and kept in the um, kept in the rotary evaporator for hydration for 1 or 1.5 hour with 100 rpm also. After that, the complete thin film with swelling and liposomal formulation was started. On that, after that we have kept in the sonicator, bath sonication or probe sonication for 1 hour, 15 minutes cycle for can be formed. After that, second day, we have uh, kept in the overnight for complete liposomal or lamellarity structure. After that, liposomal formulation, thin film hydration, we have hydration totally, bath sonication, total colloidal or milky white, and if doxorubicin daptonomycin, orangish colloidal solution formed. In the third day, we have kept in a cold centrifuge for complete separation of macromolecular structure, first 5,000 rpm and then 15,000 rpm to get unilamellar vesicles, and collect in a petri dish for kept in a overnight freeze to, and next fourth day, four consecutive day after, you kept in a refrigeration or laboratory freezer for the complete, because the thermosensitive better we cannot kept in the hot air oven or other drying purpose. For that purpose, laboratory freeze dryer is necessary for completely freeze drying, so that lyophilized state we can get, and collect in a append drop to kept in a 4 degrees centigrade refrigerator.
Dr. Niladri, are you there? I believe he has some network problem. Dr. Niladri?
Hello, am I audible?
Yes, you are audible.
Next slide, please, madam. Please, next slide. Here, antibody tag nanoliposome after lyophilization, complete lyophilization, freeze dryer. We have to collect in append drop for lyophilized liposomal formulation for characterization study, because we have to administer intravenous administration through phosphate buffer for cancer patient during cancer chemotherapy, so that we have to need characterization and evaluation. This is for passive targeting. Previously I've told we have to approach also active antibody targeting or maybe aptamer for active targeting, so that nano for anti-cancer drug loaded nano formulation can recognize the malignant cells for chemotherapy and avoid the unwanted side effect. And more, we are expecting more recovery from the cancer state here also. So antibody tag nanoliposome preparation, we have attached previously same procedure. After that we have to attach the anti-cancer drug by some linker molecule phosphoethanolamine SDP here conjugation for antibody tagged outer surface, and then laboratory we have applied FITC ERB NTHR antibody here for active targeting for then lyophilization. Please next slide, ma'am. This is the characterization. Previously we have to start morphological study, because our nano formulation nanolipid vesicle or nanoliposome is properly formed or not. So scanning electron, so many criteria is there. Same scanning electron microscopy, field emission scanning electron microscopy, transmission electron microscopy, and cryotem analysis also there. Here, field FECM images, full field emission scanning electron microscopy for tamoxifen cited nanolipid vesicles, and B, here shown antibody tagged or conjugated tamoxifen cited phosphoethanolamine as the linker molecule previously told for nanolipid. So both pictures shown that the within the 100 nanometer range, that is the next one, you are seeing the in the slide 23 nanometer, 24 nanometer is there, means uniformly they are distributed in lyophilized state and smooth spherical surface and no leakage is there. That is the homogeneously distributed and completely nanolipid vesicle evidence proved that these stages. Next, there's also next slide, please, ma'am. Transmission electron microscopy, that is the TEM images. Next slide, please. Next slide. Transmission, there is right. Transmission, that is the TEM images. A and C, that is the tamoxifen citrate loaded nanolipid vesicles. A and C show that a light spherical, because I have told the dimming preparation phospholipid and sialysin is necessary, and cholesterol also for maintain the structural rigidity. That this show the sky blue arrow shows the phospholipid vehicle surrounded the drug, means our formulation with the completely drug is loaded or incorporated, that proved. And B and D images, that is the antibody tagged or antibody conjugated, that anti-cancer drug loaded, that the more biliar phospholipid and more revealed that the darker and thicker polygonal particulate matter shown, that is shown in the green arrow for the particular area in the, so that our drug can be completely loaded in phosphoethanolamine lecithin vesicles, so that easily drug can be incorporated here. Please, ma'am, next slide. Next slide, please. Yeah. This is the cryotem analysis, another morphological study. As you know, cryogenic temperature we have need. That is the fourth one, DABCD picture. That's more within 100 nanometer range, and C, A, and D total unilamellar vesicles, because the liposomal structure are bilamellar structure. And D, you are seeing the dark arrow, that is the one unilamellar layer also there, white arrow that proved, and black portion, that is the only bilamellar structure, because liposomal structure interior wall should maintain bilamellar. Then our formulation proved the lamellarity is maintaining, and no leakage is there, and completely drug loaded, and it's maintained the axial no liposomal is a onion like structure, and lamellarity is maintained, and during the release also in vitro drug is completed silently, different time on interval, so that it maintain the steady state or longer duration of action, and sustained release action also during cancer chemotherapy. It's more beneficial to the patients also. That cryotime images is a more delicate experiment. This proof here. Next slide, ma'am, please. Next. This is the particle size analysis, because the formulation after dry state appendal, you have to administer in IV. This is the DLS technology, that is dynamic light scattering decay. In the aqueous formation, more hydrodynamic is increasing compared to dry state. It's proved that the within nano formulation 100 to 1000 range, because slightly diameter will be increase for enhancing because of their hydrodynamic aqueous solubility is there, because it is sometimes balloon like, so that in watery or aqueous portion it is more swelling compared to lyophilized state. That is a particular distribution, both A and B, that is the TN. Next one is the antibody conjugated nanoliposome, prove that within nano range it is the state. Next slide, please, ma'am. Kindly request, please. Next slide. This is the size distribution and polydispersity index and zeta potential value also. Zeta potential value proved that our stable, because reported as their minus 30 to plus 30 millivolt or MV, this colloidal solution is more stable. So our both formulation optimized for TNL1, we are seeing in the table, minus 63 plus 0.5 plus 1, that is the standard deviation we have mentioned, and phosphoethanamide conjugated for linker molecule optimized formulation minus 63.2. Both are in the negative surface charge, and mobility and conductivity prove that our formulation is stable, and it's for longer duration. It can effect from in the human blood during administration of the for chemotherapy. This is the our size distribution. So next slide, ma'am. This is the energy dispersive index. This conjugation is there or not? That is the carbon, oxygen, and some time of phosphorus also. That is the next for some shifting. This is the percentage of some carbon, oxygen, and nitrogen, and phosphorus also proved that our formulation is the conjugation antibody can be conjugated. So energy dispersive index is proved that the formulation is okay and beneficial for. This is the both TNL1 optimized formulation and antibody conjugated formulation. Slightly shifting or percentage is vary. Please next slide. This is the most important criteria. Now we have made also formulation that we have to prove the cellular endocytosis of passive targeting is possible or not. For that purpose, we have taken two cell line, that is the MCF7 breast cancer cell line, that is the estrogen receptor positive, and optimized formulation where antibody tag nanoliposome we have seen, checked in the MDMB 453 estrogen receptor negative cancer cell line also. For in vitro cellular uptake study, that is a passive targeting, we have conjugated formulation in the FITC, that is fluororesin isothiocyanate, for in the MCF7 breast cancer cell line. Here the total formulation is surrounded within the nucleus, and means in already cellular uptake or endocytosis is there in the within the cytoplasm. Means our formula different, that is the A and B, that is the formulation concentration different 100 microgram per ml for 3-hour incubation we have studied, and next formulation, that is phosphoethanol conjugated formulation for 300 microgram per ml for 3-hour incubation study. Then we have kept in confocal microscopy. Then it's proved that our formulation with endocytosis is possible. This is the passive targeting here. Next slide, ma'am. Please, next slide. This is the active targeting, means previously I have told two cell line we have taken. The first one is estrogen basis here immunoliposome, that is antibody HER-ERB 340 antibody conjugated MCF7 conjugation nanoliposome. We have applied first one A, that is the 50 microgram per ml for 30 minutes or 100 microgram for 30 minutes. Which is the active targeting? Time is less. That is the most FITC tag antibody tag liposome endocytosis or cellular uptake is possible that within the cancer cell line and engulf the or destroy the cancer abnormal cell for MCF7 breast cancer. So it proved. Next, ma'am, next slide. Next slide, please. Here, yeah, right. In vitro cellular uptake for FITC tamoxifen-cited nanoliposome, that is the phosphoethanol conjugated with antibody MDF MB453. That is the total picture ABCD4. Where this is the control, in left hand side control without untreated MD-MB453, that is estrogen negative cancer. So both competitive study and quantitative study have studied. But A and B, that is the C and D for antibody for 1 hour. A and B you have studied 50 microgram and 100 microgram per ml, and for C and D 50 microgram per ml concentration, that is the nanolipid vesicles for concentration, and 100 microgram per ml for 2 hours. And for 2-hour incubation, more FITC tagged antibody it engulf or endocytosis in NDMB 453 and previous one MCF7 cell, because of estrogen receptor positive nature, more anti-cancer drug-loaded nanoliposome entrapment or endocytosis, but MDMB453 cancer also cellular uptake is possible. Mean our formulation is entrapped or more be effective both cancer cell line, that is estrogen receptor positive and negative also. This result is proved or revealed that. Next slide, ma'am, please. This is the cytotoxicity or MTT assay we have here. MTT different micro concentration, that is the 6.25, 12.5, 225, 50 and 100. This is the cytotoxicity analysis for MTT assay. Here also drug-loaded nanoliposome formulation, that is the total here shown, that is the cytotoxicity analysis experimental study, that is the drug encapsulated liposome exhibits similar or less cytotoxicity compared to the free drug, and depending on the phase transition temperature of phospholipid used in the formulation. Surprisingly, its present study, that is the nanoliposome containing tamoxifen cited in aqueous suspension, demonstrated that they increase the cytotoxicity in MCF7 cells than free drug solution, that is tamoxifen citrate also here, diagram, bar diagram. And at the same concentration, the cytotoxicity activity of cells treated with TNL1 and TLL formulation, that is the PE also phosphated, was lower than of the cells treated with the free drug, and there is a significant decrease in cell growth for both TNL1 and TNL-PE compared to blank nanoliposome also for the highest concentration. This increased toxicity may be due to the preferential uptake of nanoliposomal formulation for TNL1 and TNLP, that is the formulation coded here, than that of free drug tamoxifen cited. The result of MTT assay revealed that the both formulation and the free drug solution acted in cells in manner for dose effect relation and had more obvious function to the tumor cells. And sustained release for drug would be capable for exhibiting cytotoxicity efficiency constantly as cytotoxicity activity and tumor shrinking properties of chemotherapeutics depend on dose and exposure time. Please, madam's next slide is. Here, IC50 value, I have calculated IC50 value calculated more cytotoxicity is the comparison or that reveal that this formulation cytotoxicity analysis here for IC50 value we have taken. Next slide is the in vitro release profile study. For in vitro release profile study, we have mentioned the sustained action is possible for drug release profile in different nanoliposomal formulation determined in vitro by measuring cumulative amount of drug released from nanoliposome over the predetermined time intervals. An in vitro cumulative percentage of drug release study showed that the drug release from the experimental formulation in a sustained manner and incorporation of phosphoethanol further delayed the drug release from different time of interval. This may due to the formation of some physical bonding between the phosphoethanol and phospholipid and cholesterol present in the biliary membrane of nanoliposomal formulation. Then this intercalated bonding network might hinder the drug diffusion through the phospholipid membrane. Further, the comparatively larger size of phosphoethanol incorporated nanoliposome might have enhanced the drug diffusion pathway that might further delay the drug release and always maintain some sustained manner. And the next slide, please. Next. Here, some in vivo, prior to this zero order cross-smear purpose operation, also in vitro release profile we have checked. Our formulation data was fitted for cross-smear purpose equation for following Fickian diffusion, that both formulation. And here, in vivo study, we have taken Swiss albino mice for in vitro in vivo study or and pharmacokinetic parameter also some there. After administration of both tamoxifen citrate and tamoxifen citrate loaded phosphoethanol linker molecule, here drug levels from them in the blood steadily declined. Here picture is shown that declined within the first 5 to 6 hours. This may due to the rapid distribution of the drug. Afterward, tamoxifen citrate levels sharply fell down till the end of the study, that is the 24-hour. And however, studies sustained and significantly higher the drug levels obtained in case of phosphoethanol and TNL. This may be because of more blood residence time of phosphoethanol TNL and faster total body clearance of free drug, that is tamoxifen citrate, as obtained from pharmacokinetic parameter study that higher area under curve, that is a higher AUC 0 to infinity and AUMC, that is 0 to infinity values support for both TNLP formulation provide better bioavailability of drug compared to free drug administration as colloidal suspension of nanoliposomal or nanolipid vesicular formulation. This further presence of tamoxifen citrate in the liposomal membrane has been reported to carry liposome more to the breast cancer cells and oncotarget here also. This is the value. Next, the slide. Here, the total pharmacology previously I have told that is the free drug tamoxifen citrate or phosphoethanol tamoxifen citrate you have administered, that the pharmacokinetic parameter we have checked in software and standard deviation we have checked in graph presence graph Prism software, statistical design, that is area under curve, that is 0 to infinity nanogram per ml. Both data shown here, and AUMC 0 to infinity, and T half is the 7 for Friedach 7.872, and T half for phosphoenol TNLP, where antibody we have tagged, that is a 12.617. And minimum residence time free drug demonstration, and we had formulation shows more increase the residence time and maintaining the MRT increasing means steady state or plateau stage in the plasma level we have checked for control release studies possible, but sustained or longer period of action for novel drug delivery system. As you know, 16.233 MRT is shown. And renal clearance here, free for free drug 0.00150, our formulation is 0.0094. And volume of distribution here, the data is shows our formulation more significantly bind with parent, so that increasing the therapeutic efficacy and cellular endocytosis. Next slide, please. That conclusion and future prospective for our formulation, that main objective is new devices and avoid, previously I've told, that is our main object is increase the therapeutic efficacy of drug molecule, and so avoiding unwanted side effect or drug reduction interaction, or avoiding the cytotoxicity during the chemotherapy of the cancer patient, so that they are more become a return the normal life. And cancer chemotherapy, during chemotherapy, more anti-cancer drug only target the cancers and not hamper any healthy cells. And the second one, the newer drug delivery system, reducing the dosage frequency and maintaining control or sustained or pre-program or predetermined time interval drug release, so that within the therapeutic range, means within the minimum effective and maximum concentration, drug is maintaining steady state for increase the minimum residence time and more increase the therapeutic efficacy and avoiding metastasis also. And third one, the ligand molecule, that is the aptamer or antibody tagged with an outer surface of nanoformulation surface, so that they recognize the more malignant or neoplastic cells and applied for active targeting, not hamper the healthy normal cells, so that is the cancer patient is more beneficial for during chemotherapy. And in most our formulation is more can influence the human health care in the during field of oncology. And thank you so much for your nice cooperation with me. And any
Sumbul, and I'm working as a specialty doctor in County Durham and Darlington. I'll be presenting my abstract on scout-guided excisions of impalpable breast lesions. It's a new technique of removing breast lesions which are not palpable. So I'll be sharing our experience of scout usage in our trust. Can you see my next slide, please? Hello?
Yes, doctor, we can.
Okay, thank you. As we all know that there is improvement in breast cancer screening over the time, and we are seeing more referrals for screen-detected non-palpable breast cancers. It's really important to localize these lesions accurately for successful therapeutic outcomes. The most conventional method of localizing these impalpable breast lesion has always been wire-guided, in which a tiny wire is inserted through the skin of the breast, and it just goes and hook in the lesion so that it can be removed later on during the surgery. This procedure is done on the day of surgery in the radiology suite, and the patient would usually be waiting with a sticking wire outside their breast waiting for their surgery. It has got limitations because by the time patient goes for the surgery, there is a possibility that the wire might have displaced. Patient will be in a continuous discomfort. and there is always some listing issues going on and need a very good collaboration with the radiology and the surgical department. Because of all these limitations, it has always been tried to find out wireless method of localization. There are few methods so far which included radioactive seed localization, MAC-seed, mammaloc, or intraoperative ultrasound guided excision, or using radio frequency localizer. Scout is an innovative localization for these non-palpable breast lesions. It uses a radio frequency identification system. It has got a reflector, which is this tiny bit, very tiny reflector. It is inserted in the breast tissue under image guidance using ultrasound or stereotactic. The marker is placed directly in the lesion, which allows precise localization. And then there is a signal detecting machine with a handheld detector. The device emits signals that are identified with the signal detector and are displayed on the screen in terms of distance. So I'll be sharing a small video which might be helpful to understand the principle of Scout. So that's the lesion in which we have inserted the Scout. It can be inserted way before the surgery. And on the day of surgery, we use the handheld probe and try to locate it. This is the distance which is of the Scout from the handheld probe. So once we have localized, we can give an incision, go directly on it, remove the lesion, and take it out. The same principle can be used to localize axillary lymph nodes, in which we can put a small lesion in the node, and when needed, we can remove that node. Okay, so the objective of our study was to assess the effectiveness and outcome of Scout-guided excision. Mainly, we were focusing on accuracy of the lesion localization, efficiency of the procedure, and overall procedural success. Data was collected from February 2023 to June 2024 of all the patients who has undergone Scout-guided excision of impalpable lesion. Evaluation criteria included histological findings and operator feedback on lesion excision. We have used 72 scouts throughout that duration in 67 patients. All our patients were female. Average age of our patients was 60 years. 97% of the scouts were inserted in breast and 3% were inserted in axilla. In 5 cases, we used multiple scouts. 3 cases were in which multifocal lesions were there, and we had to localize the scout for 2 cancers or multiple lesions in the breast, and 2 cases were in which we had to localize breast lesion as well as axillary lymph node. 76% of the procedures were therapeutic, whereas 23% procedures were diagnostic. 13.8% cases were in which the scout was inserted before patient going for a neoadjuvant chemotherapy, so that after the chemotherapy the lesion could be localized. The duration of scout insertion to excision time varied from same day of insertion in 4 cases and up to 7.5 months in patient undergoing neoadjuvant chemotherapy. Our results have shown that 70% of the cases were for malignancy. 23% cases were for B3 lesion, and 2.7 were benign and 2.7 were DCIS. For post-margin excision status, we had to do 15% re-excisions in 11 patients. These excisions were required either the margins were too close to the tumor or the margins were involved because of the tumor. The size discrepancy in these 11 patients were found, like the initial size which was told on radiology was found to be bigger on histology in 7 patients. We carried out post-operative specimen X-rays once we have removed them in 52 patients, which were done during the training period. Only one patient had post-operative hematoma, which was managed conservatively, and no other complications were reported in all the patients. We were able to remove all the scouts without any device failure or malfunctions. There were no delays or cancellation on surgical list for these patients because of any problem with the scout insertion or radiology liaison. So the strength of using Scout is that it's highly reliable, efficient, and the excisions will become reliable and efficient with the Scout. Accurate lesion localization is possible. No significant impact on surgical scheduling was found. Whereas on the other hand, we found that there was margin involvement in some cases. Well, it is still within the usual limit of re-excisions in NHS, but still we can look into the thing of size discrepancy found between histological and radiological measurements. So the conclusion would be that Scout-guided excision of these non-palpable breast lesion shows high reliability, accurate localization, and consistent procedural success. Size discrepancy and margin involvement offer area for improvement in preoperative strategy and imaging accuracy. So we can, in the future, we can focus on enhancing preoperative imaging and addressing size discrepancy, which may further improve our outcomes. Thank you. I'm open to any questions.
So I'd like to start my presentation now. So this is like a multidisciplinary research. So that's why the conference has asked me to present, even though it is a little bit away from the cancer research. It is related to the tuberculosis research. So to start with, this tuberculosis is caused by, we all very well know that it is caused by Mycobacterium tuberculosis and also bovis. And it's the most rambling communicable infectious disease on earth and remains out of control in many developing countries. So it is a burning problem in India, apart from the other countries also. And the most common cause of death next to the HIV, the other infectious diseases, and especially common in the age group that is 15 to 49 years age. And India features among the 22 high TB burden countries, and 60% cases are generally from countries, developing countries like India, China, Africa, and Russia. And every day, 600 people die out of tuberculosis. So there is a burning problem. That's why we have chosen this topic. And the most common presentation of this tuberculosis is pulmonary tuberculosis. So to have the effective treatment, so we need to have the good bacteriological diagnosis and the complaints from the patient side as well. And the clinician also need to stick to the guidelines of the prescriptions governed by the Government of India. So revised National Tuberculosis Control Program, that is RNTCP, was launched by the government in 1997. And then thereon implemented the DOTS therapy, that is direct observation short course therapy, that is designed by the government, so that there will be no more problems regarding the compliance by the patient, so that effective outcome of the therapy will be better. So then, apart from the RNTCP, the government has launched again the National Tuberculosis Eradication Program in 2020. That is a final goal by the Government of India. So we have the multi-drug regimens because the tuberculosis as such is very, we have like resistant organisms, and monotherapy is not effective. And there are also possible risk factors, that is the bacteria resides in the macrophages, and resistance will be there by the mutation. So all this will be there. So we need to go for the multi-drug regimens where there is a possibility of undesirable adverse drug reactions. And we have taken the study in collision with the comorbid diseases, tuberculosis patients suffering along with some other comorbid diseases. What are the multiple events that we can come across while prescribing the drugs to the patients? So we came across the most common areas like hepatotoxicity, most probably. So the chronic illness, whenever there is there, when we are keeping the patient on polypharmacy, along with their need of drug therapy for their comorbid conditions, medication adherence from the patient side is the most important factor that need to be valid and counted upon. So what is this medication adherence? The extent to which a patient's medication taking behavior coincides with the intention of the health advice he or she has been given. So World Health Organization also has been given another definition similar to this, that is the degree to which the person's behavior corresponds with the agreed recommendations from a healthcare provider. So we have studied, based on this, the drug-related problems that have been encountered during while treating the patients with this tuberculosis along with the comorbid diseases. So what is this drug-related problem? This is an event or circumstance involving drug therapy that actually or potentially interferes with the desired health outcomes. So it has a great connection in relation to this rational use of drugs. So clinician's role is very important in diagnosing the case and paying attention to the comorbid disease and what drug therapy we are giving in connection to the prescription that has been already given for the comorbid conditions, so that complete structure need to be maintained so that we can avoid the drug-related problems arising out of the treatment. So these drug-related problems could be, as we just now discussed, due to polypharmacy with the multiple drug regimen that we have been giving to the tuberculosis and for the comorbid conditions also. So it increases, it influences the outcome of therapy where there are too many drug interactions will be there and adverse drug reactions will be there. So it can increase the cost of the therapy from the patient side, and it can block the attainment of the therapy, the goal which we are trying to achieve, that is the tuberculosis eradication. So we have done the prospective study from January 2020 to December 2021 year. The data was collected from 200 case sheets of the inpatients from all departments except OBG, because OBG, some other complications may arise. Even though it is not an interventional study, we have restrained ourselves except OBG, because there may be some criteria for the pregnant ladies for going for the regimens. So the inclusion criteria were TB patients along with comorbidities. So only TB patients were excluded from the study, and patients of all age groups have been taken except pregnant and lactating women. Data case sheets were checked for DRPs, drug-related problems, by using the databases like Micromedics, Tricks.com database, standard textbooks and interviews from patients. And we have taken basically the broad PCNE classification, that is Pharmaceutical Care Network Europe classification. And from that, we have taken 6 categories and we have studied in detail about that in our research. So data was collected in pre-designed Microsoft Word, Excel, and then Word. And then it was expressed in terms of percentages and represented in tables and bar diagrams by analyzing with descriptive statistics. So we have taken 6 categories, as we said earlier, of the Pharmaceutical Care Network Europe, so which has studied the drug-related problems in this present research. We have seen 1,170 drug-related problems that have been identified among the 200 patients which we have taken. So the most common drug-related problems were the drug interactions found to be the prior, that is considering 52 to 50.26% wrong, and the drugs choice problem, that is 40.68%. So approximately under that category, again, inappropriate use of drugs while dealing with the case, that is 74.37%, like antibiotics and acid suppressant drugs. We'll go that in detail one by one. So hepatic impairment was the most common area that is with the anti-tubercular drugs and also with the comorbid conditions, drug-to-drug interactions as well, so which we need to pay attention to. Then future tasks based on this current study, what we have done is a clinician needs to pay more attention to the management of tuberculosis in patients who also suffer from other common chronic diseases like diabetes, hypertension as well. So when the prescription, when the clinician considers the patient in toto, not only the tuberculosis, but other comorbid diseases which he has been suffering. And the prescriptions, that is again another polypharmacy which he has been on since maybe few years like that. So in total, if we can get the knowledge of ADR because of the probable drug interactions, then we can do some benefit to the patient. Not only that, compliance of the patient also may be enhanced so that we can achieve the goal of tuberculosis eradication in the developing countries. So medication related harms, so that is one point, and medication errors also, that is another thing which we have studied in that. And these two can be prevented by when clinician pays attention to the case to case. Then strategies that we can think about is complete clinical status of each patient and structured review of patient medication by the clinicians. So this is the patient demographic data in total, which we'll be discussing one by one. So this is represented in the form of bar diagram, and this is represented in the form of table. So one by one going ahead, gender distribution, males were most affected with this drug-to-drug relation interactions and all these things. So that is mainly when compared to the females, that is mainly because of this dihydroepiandrosterone is getting converted to testosterone in the body, which has the potential to produce immunosuppression. So that is why the tuberculosis related risks or complications or ADR, everything are more in case of males. And in case of females, estrogen has the other effect that is triggering the immune response. But in case of post-menopausal females, it is equivalent to that of males because estrogen content will be less in case of post-menopausal females. So that is one point. Then coming to the age distribution, we have seen these drug-related problems most common in adults because they have the tendency to get exposed to the public more. And pediatrics and elderly people, they have less exposure, so less number of events. Then BMI, body mass index distribution. So it is like less than 60% and less than 60 kg, that is 160 events. But there are few studies which suggest that BMI less, that is thin patients, or BMI more, that is obese patients, both can have, and they have like a universal like distribution depending upon the varied response from area to area. Then family history, even if there is no family history, there are more number of related events. And DOTS category, we have taken like category 1, patients who are on category 1, that is 142, category 2, 54, and multi-drug resistant regimens on 4. So here the smokers along who are suffering from tuberculosis are more, and then next no social habits. Then comes to the smoker plus alcoholic, and this is alcoholic, that is lifestyle or habitual tendency. So then here we can see the comorbidities that we have taken. Tuberculosis patients suffering along with hepatic impairment, diabetes mellitus, lower respiratory tract infection, hypertension, COPD, which are the most common diseases that commonly occur along with tuberculosis. And we have seen here the hepatic impairment cases are more in the public, and drug-related events are also more. This is 45%, we can say, comorbidities. Then total 1170 DRPs among 200 patients. We have taken 6 categories of PCNE Europe DRPs classification, which we'll discuss one by one, all the 6 categories now. So this is drug-related problems, adverse drug reactions 10%, and then drug choice problems 476%, dosing problems 6%, then drug use problems 12%, and drug interactions 588, and the others 78. So this is represented in a tabular column. One by one, we will go now. Adverse drug reactions, most commonly non-allergic side effects, were counted to be 10. That is 0.85%. That is very least. Then coming to the drug choice problems, inappropriate drug that has been used in the management of the TB plus comorbidities was found to be 354. Inappropriate drug form 104. Inappropriate duplication of therapeutic group or active ingredient 8. Contraindication for drug were 2, and no clear indication for drug use were 8 events. Dosing problems, that is drug dose too high, or dosage regimen too frequent, that were found to be 6 in number. And then wrong drug taken or administered, taken by the patient or administered by the clinician, that found to be 12 in number. And then potential drug-to-drug interactions were appearing to be 588, which was a major event that we could come across. And then the insufficient awareness of health and diseases, both from the clinician perspective and the patient perspective, that counted for 78. So then coming to the adverse drug reactions, so this isoniazid, rifampicin, and pyrazinamide were in the basic regimen. So when the patient is suffering from the liver failure or any liver pathology, so we need to be careful either to reduce the dose or adjust the dose like that. So then there will not be possibility of elevation of LFT, which we found to be 18 number events. And then chloramphenicol, which is not supposed to be used and highly to be contraindicated, were used in this in 2 cases which were producing anemia, which was not supposed to be used. So this is represented again in tabular form. So these drug-related problems occurred in TB patients. Sometimes it were like only in TB patients were more, sometimes along with comorbidities, majorly producing drug interactions up to a major extent. So chronic comorbid conditions, regular medication will be there for the patient for the current burning problem as well as the comorbid conditions. So more number of potential drug-to-drug interactions is the most common possible factor which we need to pay attention from the clinician perspective. And then inappropriate drug. So we have seen certain inappropriate drug usage for the patients like piperacillin, ceftriaxone, moxifloxacin, gentamicin, amikacin, linezolid, chloramphenicol, pantoprazole, and ranitidine, where the necessity is not needed as a must, but still the clinician has used those drugs. So, for example, ceftriaxone, this has been indicated for several conditions like epiglottitis, brain abscess, bacterial meningitis, pyelonephritis in children, like the septicemia, etc., etc. But there is no specific use of ceftriaxone along with the basic anti-tuberculosis regimen in the TB patients, which has been used by some of the clinicians. So, anti-tuberculosis antibiotics along with the ceftriaxone is not needed. So inappropriate use is very high, so which can lead to the emergence of resistant bacterial strains. So from the patient perspective, the cost of the therapy will be high and resistant strain will be high. And also treatment failure could be a possible outcome that we may get. So then coming to the other drugs like inappropriate drugs, fluoroquinolones, aminoglycosides, and other reserve drugs, proton pump inhibitors, and H2 receptor antagonists. So piperacillin or tazobactam, it is specifically or selectively indicated for pneumonia or septicemia in neutropenic patients, or in sepsis which has not responded to first-line treatment, then only we have to keep the patient on piperacillin. So if it is not appropriate for gentamicin to be added to first-line therapy, then also we can think about this, but not as a first-line regimen. Then linezolid, which is like a reserve antimicrobial drug, which is like a drug which has been used for the repurposing conditions when all the other measures fail. And also in case of severe sepsis and clinical failure of other classes of antibiotics over 48 hours. So that could be the last resort when we keep the patient on linezolid. But the few clinicians have kept this linezolid also on the patients as a fancy thing. So which needs to be avoided. Then inappropriate drug form. So it is like drug dosage form, that is oral tablet when the patient is like able to take the oral dosage forms, then there is no need to go for the injectables, which the clinicians have opted. So that is inappropriate drug form, which has been counted 80 in number of the drug-related problems with pantoprazole injection and 16 ranitidine injection, paracetamol 8 events. Again represented in the table form. Then inappropriate duplication of therapeutic group or active drug. Even the 2 drugs belonging to the same group, so they have duplicated the clinicians like the aminoglycosides. Streptomycin already been there in the drug regimen, anti-tubercular drug regimen. Again, the patient was being kept by the clinician on gentamicin injection. So like this, paracetamol tablet was there, again injection was given, diclofenac tablet was there, and again injection was given. And then acibrofilin, which belongs to the methylxanthine groups, the patient was already there. Again, doxyphilin tablet was given. So this also need to be avoided by the clinicians. So this is again represented in the table form. Then chloramphenicol, which is highly to be contraindicated because there is a possible risk with the bone marrow suppressant activity, which produces anemia that we have seen in 2 cases. And then no clear indication of drug use like antimalarials, that is, which can be used like no drug repurposing role here, but still it has been used in 8 cases, that is lumefantrine along with artemether. Then drug dose is either too high or dose-based regimen is too frequent, especially when the patient is suffering from alcoholic hepatopathy or hepatic impairment based on the liver function test. And then we have to adjust the dose of the basic regimen drugs like isoniazid, rifampicin, or pyrazinamide. So that dose adjustment is not done. Dosage regimen frequency is not done in 6 number of cases here. Then wrong drug being administered to the patient. That is, example, montelukast has been indicated only for chronic asthma or exercise-induced asthma or even seasonal allergic rhinitis. But still, even the patient is not suffering from these conditions, the montelukast has been given to the patient. That is it. That has been reported in 12 number of cases. Then finally, the drug interactions. Major drug interactions counted for only 8 and moderate drug interactions because of the polypharmacy, the anti-tubercular regimen, and also the polypharmacy that the patient have been already taking for his or her comorbid conditions. The moderate drug interactions were being reported in around 580 patients, so which is too large in number. So the clinician has to pay attention very much to this to give a quality of improvement to the patients. So then the conclusion after evaluating all these 6 aspects of the PCNE classification. So non-adherence to the prescribed therapy. So that is leading to the drug-related problems causing hospitalization at higher incidence followed by ADR. So because of the multiple drug therapy, the patient may not be willing to stick on to the therapy. So non-adherence could be a problem from the patient's side, which will not make us achieve the goal of tuberculosis eradication. Most identified risk factors could be because of lack of knowledge about the disease by the clinician. Could someone mute that, please? And the other most identified risk factors could be lack of knowledge about the disease, need of adherence to the therapy as prescribed. The clinicians need to stick to the guidelines given by the government, especially the World Health Organization guidelines. Then outcomes of treatment provided the clinician has to keep in mind when combining the anti-tubercular different sorts of regimens when combined with the other prescriptions given for comorbid conditions. So here, the conclusion of my study is the severity of DRPs was majorly assessed to be moderate, but it was very huge. Out of 1170 cases, 580 such moderate drug-to-drug interactions were being reported. So my references are these. Thank you. Thank you for giving me this opportunity for presentation in this wonderful conference.
These are the authors, my name, and then the co-authors. By way of introduction, breast cancer is the most common cancer in women worldwide and also the most common cause of cancer-related death in them. And that is the report by Globocan 2020. Oman Cancer Registry in 2020 also reported that carcinoma of the breast represents about 25% of cancers in women. Neoadjuvant chemotherapy is
Dr. Nazaruddin, we cannot hear your voice.
Hello?
Dr. Nazaruddin?
Yes, can you hear me?
Yes, we can hear you, doctor.
Sorry about that. It was a network
It's
issue, and
okay.
then
No
I've
problem.
corrected it.
Please proceed with your
So I will be
presentation.
discussing ultrasound, accuracy of ultrasound and mammogram in tumor response assessment following neoadjuvant chemotherapy in breast cancer patients. This is a single center experience. That is our center. It's my name and the other co-authors. As a way of introduction, breast cancer is the most common cancer in women worldwide and also the most common cause of cancer-related death in them. That is by Global Count 2020. And also, Oman Cancer Registry 2020 also reported that carcinoma of the breast constituted about 25% of all breast cancer in women. Neoadjuvant chemotherapy is commonly used to reduce tumor size prior to surgery to facilitate breast-conserving procedure, which is what most patients with breast cancer actually wishes for. And it also offers valuable prognostic insight by in vivo assessment of the tumor response to treatment. Magnetic resonance imaging, that is MRI of the breast, is considered the gold standard for monitoring treatment response due to its superiority in terms of sensitivity and also, but the high costs, the limited availability and potential to induce claustrophobia and the risk of false positive findings have led many healthcare facilities to rely on alternative imaging techniques such as ultrasound of the breast and also mammogram. The aim of our study is to assess the accuracy of combined breast ultrasound and mammogram in predicting pathological response in breast cancer patients. It was a retrospective study of breast cancer patients who received treatment, that is neoadjuvant chemotherapy, and also completed surgical treatment between January 2021 and June 2024. All these patients had ultrasound, breast ultrasound, and mammogram before neoadjuvant chemotherapy, and also they were also evaluated for response 2 weeks after completion of neoadjuvant chemotherapy. Their results were compared with final histopathology. We group these patients into 4 based on their immunohistochemistry. We have hormone receptor positive one and HER2 receptor positive into one group. Hormone receptor positive, HER2 receptor negative, another group, that is group 2. Group 3, hormone receptor negative, HER2 receptor negative. That's group 3. Then group 4, hormone receptor negative and HER2 receptor negative positive into group 4. These are the groups. So in our results, we analyzed the result of 145 patients altogether. This is excluding patients who were lost to follow-up, patients who had metastatic disease, patients who had upfront surgery, and then patients who could not be operated for other purposes like progression of the disease and other things. So the mean age of the participants in this study is about 45 years. And then the overall, in our study, the most common histology of breast cancer is invasive ductal carcinoma, which constituted about 75.5% of all the patients. And the most common subtype of tumor in terms of immunohistochemistry is hormone receptor positive and HER2 receptor negative. That constituted about 46%, about 47% of our study participants. The overall response, which is shown in table 1 here, is the partial response in the radiology, they were 95%, while the complete response radiologically is 50%. The partial response, pathological response is 87%, is 60%, sorry, while the complete was 40%. If you look at the p-value, is 0.39. That shows that it is insignificant when we compared the two, because the p-value is much less than 0.05. The subgroup analysis, is actually the table 2, is the one that gives us the broad idea of what we are actually discussing. Looking at the subgroup of each of these patients, the HER2 positive, the L2 negative, the hormone positive, L2 negative, and all that. If we look at all the p-values for each of these subgroups, we see that they are non-significant except for hormone receptor negative and HER2 positive. That is where we have the p-value of 0.04 and also the lowest accuracy of 75.8%. The others, the HER2 positive, the hormone receptor positive, the sensitivity, the accuracy is 94.5, while the hormone receptor negative and the hormone receptor negative, HER2 negative, the accuracy is 91.2. All these shows that using ultrasound and mammogram and then comparing it with histopathology, final histopathology shows that the accuracy of imaging in that regard is low. And it's based on this that we conclude that combined breast ultrasound and mammogram have less accuracy in predicting pathological response, particularly in hormone receptor negative and HER2 positive patients. And then we are also saying that we want to consider using breast MRI in initial evaluation and also the post-operative assessment of neoadjuvant chemotherapy in patients with this subgroup of tumor, that is hormone receptor negative and HER2 positive patients. These are my responses, my references. If there are reasons to, there are questions, I'll be willing to answer them. Thank you very much for the opportunity. Thank you. Thank you. Thank you. This is the end of my presentation. It's an e-poster presentation. Thank you.
Asia country with a population 1 to 20 million, more than 20 million population, and the Shimken city by a medical oncologist from this city, and the head of chemotherapy and endovascular oncology department. So actually, the majority of malignant tumors of the hepatobiliary tract are cancers of the pancreas, liver, and gallbladder. Pancreatic cancer and the tumor today remain on one of the most pressing aspects of clinical oncology. At first time of all, this is due to the fact that most patients at the time of initial diagnosis have to so-called advanced stage of the disease with metastasis to parenchymal organs or severe pain caused by tumor compression of the tract. The purpose of the study was to evaluate the possibilities of intraarerial treatment methods. Liver and hepatobiliary duct is a common and third most diagnosed cancer in the world. Biliary tract cancer accounts for 10 and 50% of liver cancer, but accounts for less than 1% of all cancer. There is around 900,000 new cases in the world, and more of them death in the world. It's a very high mortality number. In Kazakhstan, as in the world, hepatobiliary tract is a rare and very aggressive malignant pathology. In the structure of the morbidity and mortality in the Republic of Kazakhstan, liver cancer and cancer of intrahepatic and extrahepatic bile duct and gallbladder cancer are associated together. There is 1,000 liver cancer, and about 10% is cholangiocarcinoma, and 9% is extrahepatic location, and 10% is intrahepatic location. The men's is more than women's. However, such morbidity and mortality persist throughout the world despite and the development of technologies focused on early diagnosis. There are many and large number of scientific publications devoted to this topic, but all of these data indicate on overall survival it's around 6 or 8 months. just one. In 2010, a combination of chemotherapy drugs, gemcitabine and cisplatin, was recognized as the standard of care for the treatment of advanced biliary tract cancer. What about NCCN recommendations and NCCN guidelines? The primary treatment include the laparoscopic staging and reduction and regional lymphadenectomy, and other options include systemic therapy. And it's a more important that arterially directed therapies also. All of drug treatments include fluoropyrimidine-based chemotherapy and hemorrhagation, or gemcitabine-based chemotherapy followed by. This one is also the same recommendations, the cholangiocarcinoma in the intrahepatic and the extrahepatic location. Let's speak on intraarerial chemotherapy as option right now. We have 20 patients aged from 36 to 58 years were treated. 8 patients with a verified diagnosis of liver cholangiocarcinoma and 11 patients with a primary diagnosis of pancreatic cancer of varying degree and the pain severity. In all of patients, stage 4. And we used according to the recommendation, all of patients are recommended undergo cirrhosis, palliative polychemotherapy with elements GEMOX. The frequency of the procedure was carried out every 2 or 3 weeks. Some examples from our experience. You can see intraarterial chemoinfusion with the embolization agent combination. You can see a tumor in the right hepatic artery with a catheter. Do it again with a large tumor size. And right picture is the after used operation. The tubercular accumulation contrast agent in the right hepatic artery. This one is area. As a similar intraarterial chemoinfusion with a super selective embolization agent combination. You can see double blood supply in the middle of the liver and the right hepatic artery and left hepatic artery. This one is size. And after use of operation, no contrast agent and no tumor. As the same intraarterial chemoinfusion without any combinations. I mean, some combination with the embolization agent. So primary cholangiocarcinoma of the liver in a 29 years old patient with an intraorgan metastasis in 29, in good condition 1. You can see primary cholangiocarcinoma of the liver with the same patient with an intraorgan metastasis with a PET-CT visualization. You can compare results after 8 courses of chemoinfusion in hepatic artery. Overall survival for this patient was 2.4 years, include observation period. Another patient with a similar disease, primary cholangiocarcinoma and 32 years old. At 20 and 21, echo condition is 1. You can see multiple intrahepatic metastasis of cholangiocarcinoma condition before treatment. And the same patient, treatment to be continued. The same patient at 20 and 22, and the same patient in the 20 and 23. This primary cholangiocarcinoma, and this patient also. In nowadays, a CT scan of cholangiocarcinoma with intrahepatic metastasis condition after treatment, 40 courses, intrahepatic heminfusion with GMOX with interval observation of the stability of disease. Overall survival consists 2 or 3 years for these patients. Our results, according to the control examination, stabilization of the process with a positive dynamics was noted in 10 patients with pancreatic disease, and 1 patient had partial regression, and 1 patient had progression of the process against the background, and 3 courses of transarterial chemotherapy. Decrease of pain was observed in a 100% of cases after 1 courses of hemo infusion. It's very important in our experience. And finally, we just want to use the example of our experience and result to report that this technique is justified and has very good results. But in overall survival and in improving the quality of life of patients. I would like to finish my presentation with some words. Agreed, Steve Jobs, the best people are the ones who make you smile the most. And to be needed by someone is happiness. If you can give someone a smile for one day, then it's double happiness also. I am finished. Thank you for your attention. If you have some question, I write my mail address, okay?
Thank you, Dr. Isamicharo. That was an
Dr. Rajesh Arrow and Principal PG College of Pharmacy, Nandurbar. So my content of seminar is abstract, introduction to cancer and plants, material method, result discussion and conclusion. So my abstract is, so what is the summary or we call as the abstract? So my basic aim is to find out the anti-cancer activity in plant we call as the abelmoschus manihot by taking the aqueous extract. So what is my material method? So first I'm collecting the roots of abelmoschus manihot and it is extracted with water by maceration method and tested against the ovarian carcinoma of PA1 cell lines at number of concentrations. And also there is a cytotoxic activities done on brine shrimp larvae. The larvae is one of the stage. Okay, that is the first step of that brine shrimp. And the phytochemical analysis it is done by HPLC. HPLC, we all know that these are the newly developed techniques. So what is the result and conclusions? So as per my result and conclusion, so my roots shows a good anti-cancer activity at 40 microgram per ml when we compare with the standard drug that is a cisplatin. And in cytotoxic activity, it shows 1 mg per ml. It shows a good activity by killing the non-poly at 1 mg per ml. Phytochemical analysis of extract indicated the presence of flavonoids, tannins, gallic acid. Based on their results, it is concluded that the roots of abelmoschus manihot it shows good anti-cancer activity for the treatment of ovarian cancer. So my next point is that introduction to plant and a review of literature. So, introduction to cancer. We all know that cancer, it is the fastly grow disease in the 20th century as well as the 21st century. Presently, now there are lots of new anti-cancer agents was discovered from natural products. So, about 1 in 5 people develop cancer in their lifetime. Approximately in 1 in 9 in men and 1 in 12 in women die from this disease. So, plants play a vital role in the treatment of cancer, as we all know that. So, it is estimated that the plant-derived compounds, one of or other way, constitute more than 50% of anti-cancer agents. Introduction to abelmoschus manihot. So, abelmoschus manihot, it is belonging to family Malvaceae. It having height up to 2 centimeter and commonly known as a jungly vendi. It is mostly found in various parts of India like Konkan, Western Ghats and Western coast of India. So biologically, it shows the nephropathy, antiviral, anticoagulant, adaptogenic, anti-inflammatory, analgesic, and having the anti-cancer, anti-convulsion activity. So various parts of abelmoschus manihot. So it shows these are the number of parts, roots parts. So these images are not seen here. Flowers parts, fruits parts, and leaves parts. These are the number of parts of that abelmoschus manihot. So what is my material method? Material method, that is the first step is that what is the procurement of plant material? So it is collected from the local area of that Maharashtra, India, and it is authenticated by the authentified person, and then the extraction process is done by using distilled water, shed under dried and crushed into coarse powder and extracted with the maceration method. And then extract was dried, and this dried extract was used further for the preliminary phytochemical test for the presence of different chemical classes of compounds. So the first activity is that cytotoxic activity. That is we call as the brine shrimp lethality assay. So here, what I am done that take the brine shrimp eggs. These are purchased from the fishery shop. These eggs was hatched in the saline water, that is sea water, that consists of a number of salts. It is hatched for 48 hours with the help of bright light source, and then after that hatching, we got the brine shrimp larvae. Prepare the number of concentration of aqueous extract, okay, and then add this napoli, or we call as a brine shrimp larvae, into that aqueous extract, and finally after 24 hours noted that there are number of napoli that should be killed. We call as the LC50. Here we calculate the LC50. LC50 means the lethal concentration required to kill the 50% of population were determined using probit method. So second part is that is the anti-cancer activity. So here these are the anti-cancer activities done by MTT assay. So here the cultures, these are the various steps. It consists of gentamicin, that is a number of media. So collect the human ovarian cancer cell lines, prepare the cultures, and these cultures are sent for anti-cancer activity. So next one is that after preparation of cultures, after preparation of cultures, after preparation of cultures, the cancer cell lines. So here we have to study the cancer cell lines, okay, by preparing into number of medias. So after 48 hours, we got the, that is we using the DMSO solvents. So these are the number of steps. Prepare the number of concentration of that aqueous extracts, and then act against that cell lines. We call as a PA4 cell lines by using the MTT assay. So next one is that morphological studies. So after the cell cultures and study the cell lines, Morphological studies is also done by using the by using the magnifications by treated with the aqueous extract of the roots of abelmoschus manihots. So third step, that is the phytochemical analysis. It is done by using the HPLC, we call as a high performance liquid chromatography, was performed on aqueous extract by using gallic acid as a standard, or we call as a standard marker. So here there are a number of columns are used. Column that is we call as a phenomenics C18 column. The separation of gallic acid was achieved by using methanol and water as a solvent. We call as a mobile phase. Flow rate was adjusted at 0.7 ml per minute and detection was performed at 280 nanometer. So what is my result and discussion? So in cytotoxic activity, you can observe that in that table we call as a table number 1. So for zero concentration, the number of Napoli it is 10, and the number of live Napoli at day 1, day 2 it is 10, 10. So there is no killing of that Napoli. At 1 mg per ml, the number of live Napoli at day 1 it is 10, and for day 2 it is 0. So the LC50 was 100. And at 100 microgram it should be 10, it should be 3. So the LC50 it is shows better in 1 mg per ml as compared to that of 100 microgram per ml, 10 microgram per ml, and 1 microgram per ml. So the result shows that at 1 mg per ml it shows a good cytotoxic activity. Anticancer activity it is done by using MTTS. So it is generally for PA first HeLa cell lines. It is for ovarian cancer. So after preparation of that extract, so you can observe that in table number 3. So at 40 mg per ml, it shows a good IC, that is the IC50 value. It is called as the inhibitory concentration of the cell lines. So it shows a better activity as compared to that of the cisplatin, that is at for 2.5 microgram per ml. So these are the morphological studies. Photograph shows normal HeLa cell lines, and for figure 2, that is for 10 microgram per ml, for 20 microgram per ml. So these are the photographs. So you can observe that for normal HeLa cell lines, and for 10 microgram, for 20 microgram. This is for 40 microgram and 80 microgram per ml. So these are the phytochemical analysis. So you can observe that the one of the big peak, it shows the presence of gallic acid as a standard mark, called as the chromatogram of standard gallic acid. When this standard gallic acid it is compared with my aqueous extract, it also shows the presence of gallic acid in my aqueous extract. So this will conclude that my plant shows, or plant consists of gallic acid, and gallic acid it is shows good anti-cancer activity. It is also one of the strong point to show my plant as a good anti-cancer activity. So what is my discussions? That abelmoschus manihot roots have numerous therapeutic utilities in folk medicine such as antioxidant activity. So many researchers shows that it shows strong antioxidant property, will also have potential anti-cancer property because of the role of free radicals in the development of the cancer. Phenolic compounds have been reported for their anti-cancer activity. Phenolic compounds were mainly found in abelmoschus manihot roots by using total phenolic content by using folate catalase acid. This finding was further supported by brine shrimp lethality assay, as earlier we see that at 1 mg per ml it shows a good cytotoxic activity, so which clearly indicated the toxic effect of extract. And it is reported that phenolic compounds such as gallic acid and flavonoids are the major components of extracts, and its capacity to inhibit the cancer cell proliferation, which provides the evidence that it may be the principal factor responsible for cytotoxic effect of extract. As the cytotoxicity is an indicator of a wide range of pharmacological activities such as anti-cancer, antiviral, insecticidal, pesticidal, and AIDS. So phytochemically, abelmoschus roots were rich in triterpenoids and polyphenolic constituents. So the major polyphenolic abelmoschus roots were identified as the gallic acid. Polyphenols are well known for their anti-cancer activity. These molecules might act cancer-blocking agents, preventing initiation of the carcinogenic process, and as cancer-suppressing agents, inhibiting cancer promotion and progression. The anti-cancer property of gallic acid on ovarian cancer cell and other cancers was previously reported, which act by inhibiting the growth of cancerous cells. So earlier I shows the peak shows the gallic acid in standard as well as my extract. So gallic acid, because of the presence of gallic acid, it shows a good inhibiting property against the ovarian cancer cells. Thus we assume that the anti-cancer activity of abelmoschus manihot root may be due to the presence of phenolic compound in the extract. It may be further concluded that the presence of gallic acid and other similar phytochemical constituents present in the extract may contribute to cytotoxicity and cancerous cell growth inhibition. So what is my conclusion is that the plant, as per the presence of phenolic compounds, as per the results, it shows the good anti-cancer agents in a traditional way of system of medicines. So the further newer researcher, it is a challenge for the new researcher to do the further work and to find out the number of active constituents present that will be responsible for the anti-cancer activity. Thank you. Thank you. Thank you. Thank you for listening patiently. Thank you, madam.
Thank you, Dr.
Hello.
Rajesh, for your wonderful presentation. So, are there any questions for Dr. Rajesh?
And status epilepticus, it's a case report. So I will talk in this presentation introduction for 5-FU chemotherapy, and also I will talk about side effect of 5-FU. It's a common side effect and rare side effect of 5-FU, and also I will present the details of patients admitted to our unit in critical care units, and also I will present clinical findings upon admission and the therapeutic intervention that have been done for these patients during his hospitalization, ICU hospitalization, and the follow-up and outcome after receiving intervention. And also I will explain treatment modalities that have been suggested in literature, and also conclusion of my presentation. In the beginning, as we know, 5-FU is anti-immobilitics and anti-neoplastics agents that have been widely used as adjuvant chemotherapy for a variety of cancers, such as carcinoma of the breast, pancreas, colon, rectum, and the stomach. And also continuous infusion 5-fluorouracil is a first-line therapy for metastasis breast cancer. Fluorouracils might be used in chemotherapy treatment regimen for invasive breast cancer, including triple-negative breast cancer. As we know, 5-FU is chemotherapy have been widely used in a treatment of different cancer as adjuvant and metastasis setting. The common side effect related 5-FU are gastrointestinal toxicity, such as nausea and vomiting and diarrhea, as well as stomatitis and myelosuppression and hand and foot syndrome and coronary vasospasm. But only 5% of the patients who receive 5-FU have been reported to experience neurotoxicity symptom, which described in literature as hyperammonia encephalopathy, Wiering's encephalopathy, and cerebral type syndrome, and subacute multifocal leukoencephalopathy. So a 51-year-old male patient admitted to critical care unit he has history hypertension and DM and chronic kidney disease with estimated glomerulus filtration rate. It was 12.5. The patient underwent EGD endoscopy related to epigastric pain for 1 year's duration. The EGD result shows 10 centimeter by 5 centimeter mucosal lesion. The biopsy result shows that the patient has gastric adenocarcinoma. There were no evidence of metastasis to the lymph nodes or the vital organ. So the patients underwent subtotal gastrectomy. The histopathologist shows poor differentiated adenocarcinoma with T&M staging T1, N1, M0. The patient was commenced on single agent 5-FU in an adjuvant setting due high comorbidity and low glomerulus filtration rates. The chemotherapy dosing, it was based on body surface area. The body surface area for that patient, it was 1.74. First, the patients give calcium folonate 400 milligram. After that, we give 5-FU 400 milligram. And after that, we give 240 milligram. So the patients total received 4,186 milligram. It was infused over 46 hours. After 6 hours of completion the dose, patients developed altermentation and seizure. The patient's family transferred him to the hospital where he was admitted to intensive care unit. Upon the admission, the patient's vital signs were stable. He was in room air. The patient only was drowsy with equal and symmetrical pupil reaction. He was actively seizing with intermittent right side neck turning and tonic-clonic seizure lasting for a few minutes to a minute, to a few seconds to a minute, with no regaining of consciousness in between. All lab tests have been done for this patient. The blood work shows elevated level of creatinine. It was 339, and urea it was 14.8, and C-reactive protein it was 82. The results of other lab tests such as complete blood test, electrolyte and glucose and ammonia and thiamine and ABGs and blood pH and liver enzymes was within normal range. Chest X-ray also it was within normal range. CT scan without contrast shows unremarkable findings. So CSF examination have been done, showed total leukocytes count, it was 2, so it is within normal range, the normal is from 0 to 10, and CSF glucose was 6.2, and CSF protein level, it was 244. CSF gram stain and culture were negative, and acid-fast bacilli and fungal smears along with CSF viral screening were negative, and serum glucose level, it was 8 millimole. CSF paraneoplastic antineuron antibodies were negative, and CSF autoimmune encephalitis antibodies, serum paraneoplastic antibodies, neural antibodies, and serum autoimmune encephalitis antibodies were negative. The dehydropyridamine dehydrogenase genotype was intact. So MRI have been done for this patients. It shows that there is intensity signal involving bilateral thalami along with bilateral cortex of occipital lobe and hippocampus. This is the results of initial MRI for the patients. EEG also have been done. It shows multiple electrographic seizure arising from left temporooccipital region. The therapeutic intervention that have been done for the patients, during the patient's staying in ICU, he was managed in line with refractory status epilepticus. He was initially intubated and sedated, and multiple anti-epileptic medication were started for him, including levocitram, valproate, luxmite, and topromate, along with IV thiamine were started for him. Later, we start IV methylprednisolone for 7 days, along with the course of the treatment. The patient's EEG control and EEG showed diffuse slowing of background activity. 2 weeks post-admission to ICU, the patient showed mild clinical improvement in terms of his consciousness level. He extubated and remained seizure-free. After 9 weeks of initial presentation, IV methylprednisolone 1 milligram and IVIG giving for 5 days, the patient has shown improvement in his consciousness level and comprehension. His disorientation improved over time during the hospitalization stay. The patient was physically rehabilitated and discharged home. 2-month follow-up in outpatient setting, he was functionally independent, alert, and oriented with minimal memory impairment. A brain MRI showed, after 2 months, showed partial improvement in hyperintensities in bilateral thalami, but persistent hyperintensity signal in occipital cortex. So this is the results of MRI after 2 months of receiving 5-FU. So such this case, there is many treatment modalities suggested in literature. It's ranging from supportive measures to use of corticosteroid and the plasma exchange and thiamine along or in combination therapeutic consistently. The mainstay of treatment remains the withdrawal of 5-FU. Uridine tricetate, the antidote of 5-FU, has been proposed as the treatment for severe 5-FU toxicity and should be considered in severe case with the hydropyrimidine dehydrogenase deficiency. Although the exact mechanism that underlie the various neurotoxicity are poorly understood, several theory has been proposed, including Krebs cycle suppression that suggested caused by fluoroacetate, which inhibit the adenosine triphosphatase dependent urea cycle, causing hyperammonia and lactic acidosis. But in our case, the patients did not present with hyperammonia. So 5-FU, as we know, penetrate the blood-brain barrier and can result in neurotoxicity, which is an uncommon side effect with a described incidence 5% only in the literature. These could be acute or delay reactions. Acute neurotoxicity usually presents as hyperammonia encephalopathy, Wings encephalopathy, and cerebral type syndrome, and delay neurotoxicity manifests as acute multifocal leukoencephalopathy. The diagnosis basis of 5-FU inducing encephalopathy includes the development of encephalopathy during the short time after 5-FU administration, along with exclusion of other metabolic, somatic, and drug-related causes. So it's described in literature as dehydropyrimidine dehydrogenase deficiency is an enzyme responsible for the breakdown of 5-FU, and its deficiency lead to 5-FU accumulation, with neurotoxicity effects such as demyelination and increase of cellular thiamine metabolism, leading to Ring's encephalopathy-like manifestation. The different side effects might be happen such as stroke, encephalopathy, central nervous system infection, and psychogenic disorder. So 5-FU related encephalopathy is a rare but potential side effect. The patients can present with different stage of altered sensorium. The presence of hyperammonia can lead to the diagnosis, but a normal level of serum ammonia does not exclude the diagnosis. It's crucial for oncologists and neurologists to remember and understand this morbid side effect, so a promote diagnosis is made with a 5-FU withdrawal and supported treatment is ensured. So thank you. That's all. Thank you for listening, and I am ready to receive any questions. Thank you. Any question?
Thank you, Dr. Aid, for your wonderful presentation. So, yes.
I have some problems. Bit delay. 1 second, please. Thank you. So, chronic granulomatous mastitis is a rare benign chronic inflammatory condition of breast, which may mimic carcinoma, often making the accurate diagnosis challenging. So in this picture, you can see there's a inflamed breast. The differential diagnosis could be underlying abscess with the cellulitis or mastitis, or inflammatory carcinoma can present like this, or this is actually a picture of chronic granulomatous mastitis. So the purpose of this study is to is to analyze the symptoms, establish accurate diagnosis, and optimize the treatment, thereby reducing the morbidity. So coming to etiology, so it's usually idiopathic, and the pathogens underlying this condition is with the various problem, including infection. Occasionally, it causes separative necrosis, and it's thought to be caused by obstruction and rupture of the duct. On the table shows the infection etiology, which include Mycobacterium tuberculosis, that's most common in developing world, and other infections like blastomycosis, cryptococcosis, and actinomycosis, filaria, corynne bacterium, and some autoimmune disease like granulomatous mastitis, giant cell arteritis, and foreign body sarcoidosis. And ductectasia, secondary to periductal mastitis due to chronic smoking, can be one etiology. And it also observed in diabetes mellitus and raised prolactin levels. So this is actually a retrospective study, and the data was collected retrospectively for the period from 2019 to 2024 from electronic password protected database at my hospital. And the aim of study was to identify symptoms, correct diagnosis, optimize treatment, and thereby reducing the morbidity. And the data, when we collected the data, we got 32 patients over the last 5 years, and we excluded 15 cases because they were already under the follow-up or under the treatment for breast cancer, and remaining 17 patients were further analyzed. So this is the chart of the clinical presentation. The commonest clinical presentation was inflamed lump in 47%, and another was painless lump. It can be swollen, deformed breast. Axial lymphadenopathy was observed in 6% of cases. And most morbid clinical symptoms was chronic discharging sinus or fistula of the breast. And we observed some axial lymphadenopathy in some patients, especially with the silicone implants. And all the presentations warranted investigation into the breast cancer. All the patients offered triple assessment from the breast unit. And it's also a diagnosis of exclusion. We need to exclude the cancer first in these cases. As a part of triple assessment, patient will have the clinical assessment and radiological assessment, including mammogram above 40 years and ultrasound less than 40 years, plus or minus biopsy. And as I mentioned before, there was 2 out of 17 patients were related to previously placed implant. They presented with axillary lymphadenopathy. And these are the results. We analyzed the radiological findings, pathological findings as well. So the most common radiological findings was ill-defined mass in five patients. That is actually radiological findings of cancer as well. So we won't be able to rely on radiological findings to confirm the diagnosis of chronic granulomatous mastitis. And other radiological findings were well-defined mass, cystic area with thick and wall, diffuse changes, evidence of silicone extravasation. And the pathological finding most common was chronic granulomatous mastitis with fat necrosis and ductectasia of 11 patients. And classical finding of chronic granulomatous mastitis was observed in 3 cases. That include chronic lobular granulomatous mastitis with lipogranulomatous mastitis. And suppurative changes were observed in 3 cases with underlying infective etiology. One patient was detected with Mycobacterium, one had corynne bacterium, and another had a rare variety of Staphylococcus bacteria. And the most common age range was 50 to 59, even though age range varied from 31 to 34 to 81. And the treatment offered was most conservatively managed initially with antibiotics. 13 patients were initially offered antibiotics, and 1 patient required surgical excision or debridement, and 3 patients were referred to rheumatology. These patients were not responding to 2 to 3 doses of antibiotics, and those patients required oral steroid prednisolone, and one patient required methotrexate immunosuppressant as well. So we considered these are the limitations of our study. Pregnancy and lactation. We did not include pregnancy and lactation in this study. This would be an important focus in the future with a more varied cohort. And malnutrition and sanitation. There was a small population of patients where malnutrition, poor sanitation may have been contributing factors. However, more research is needed in this area. And some patients are also excluded who already are diagnosed with breast cancer or under cancer follow-up. So summary, the study allows to consider chronic granulomatous mastitis as a diagnosis after the exclusion of malignancy with the biopsy, and help care of the patient with the granulomatous mastitis with more knowledge and aiming to reduce the morbidity. So we observed the age, most common age was 50 to 59, and the common presentation to clinic was inflamed lump. Evidence of silicone extravasation was an important factor. However, diffuse change and ill-defined mass were also more common. And the pathological findings were chronic granulomatous mastitis with fat necrosis and ductectasia. And recent meta-analysis has shown that the combination therapy is more useful in managing chronic granulomatous mastitis, that incorporating antibiotics, steroids, and surgery than monotherapy. So more prospective future work in chronic granulomatous research is needed to standardize diagnostic criteria and reporting guidelines that will be important for developing treatment protocol. Thank you. Any questions? Hello. Hello.
Thank you, Dr. Nidhi. Thanks for your wonderful presentation. So is there any question for Dr. Nidhi from the audience side?
Nanofibers for effective growth inhibition of lung cancer cells. Possible application in prevention of lung cancer local sources. Our background, lung cancer remains a global challenge, and further chemopreventive therapies are still immediately required. Emergencies evidence has related the potential anti-cancer effect of rutin. Rutin-loaded nanofibers have the potential to enhance cancer treatment by increasing the death of cancer cells. Objective does the explore an effective, efficient chemopreventive strategy for lung cancer, the anti-proliferative effect of rutin and rutin PCL collagen nanofibers against breast cancer cells were assessed in that study. This study investigates the anti-proliferative and apoptotic effect of component rutin and PCL collagen nanofibers against rutin cancer cells, against lung cancer cells. The study evaluates how rutin and antioxidant and anti-inflammatory components. The rutin is antioxidant and anti-inflammatory component can inhibit the growth of cancer cells through the use of nanofibers. We have ethical committee approval for this study. The method was rutin incorporated electrospan nanofibers were successfully fabricated via electrospanning and characterized through dynamic light scattering, which we say DLC, Fortran transform infrared spectroscopy, and field emission scanning electron microscopy. The cytotoxic effect of nanofibers were evaluated on NSF7 breast cancers. That is electrospanning devices for which we use for the study. And that is the A1 PCL and PCL combined nanocollagen, PCL collagen scalp on over this cover the slips. One of them normal PCL, one of them is PCL collagens. And anti-proliferative and apoptotic effect of rattan PCL collagen nanofibers were evaluated using MTT and follow cytometric assay, respectively. Also, real-time polymerase chain reaction, real-time PCR, was used to determine the gene expression levels of apoptotic genes. The result of our study, the results showed that electrospanning of 10% PCL collagen blend produced a bead-free electrospan meshes with average diameter in the range of between 300 and 400. Also, loading of rattan into the nanofibers provide mechanical properties than without drug-loaded NPC. That is the in vitro degeneration of electrospanning PCL nanofibers on the time. That is the same microprobes of PCL collagen nanofibers. PCL Schofield over structures with collagen or without collagens. Fiber diameter distribution by the time, the PCL collagen is much more active than PCL. That is the rattan PCL collagen combination. Rattan PCL collagen is much more active than normal rattan. That's why for preventing, as a prevention of or before chemotherapy or after chemotherapy, after surgery, we should use rattan PCL collagens as a preventive chemotherapy after chemotherapy or preventive of cancer. MTT assay shows that loading of rattan into PCL collagen nanofibers extends noticeable cytotoxic in the human lung cancers. That means rattan into the PCL, rattan combination with the PCL collagen, get cytotoxicity, much more active cytotoxicity in the human lung cancer cells. That is mean rattan into PCL collagen nanofibers is much more effective on the toxic cells or cancer cells. This result was associated with the alteration the mRNA levels of BEX, BCL2, P53, cycling D1, caspase3, caspase7, and H-TERT genes. The MTT assay shows that when the component rattan is loaded on the PCL collagen nanofibers, it exerts a strong toxic effect on the human lung cancer cells, which is A549. This effect is associated with activation of specific genes and enzymes, including which genes and enzymes? Genes that triggers cells apoptosis, such as BEX, P53 and BCL2. Genes that regulate the cell's cycle and cell's division, such as cycling D1 and H-tert. Enzymes involved in apoptosis, such as caspase-3, caspase-7, all of which lead to changing in the mRNA levels of cancerous cells. Its effect, rutin combined with PCL collagens, affect the mRNA levels of cancerous cells. Its mean is positively efficiency on the cancer cells. As a conclusion, change in the mRNA levels of these genes reflect the genetics response of cells to the treatment or drugs. In this case, rutin and rutin-loaded nanofibers was effective on the genetic of cells. Especially the high expression of genes associated with apoptosis indicates that cells that has been triggered and that the treatment is effective as a chemopreventive treatment or prevention from the all of cancers. The drug-loaded nanofibers showed that excellent capacity to inhibit A549 lung cancer cell in vitro than the free rutin. Therefore, the fabricate drug encapsulated with NFS may achieve a safe and suitable application for lung cancer replies rate after surgery. The drug-loaded nanofibers were much more effective at inhibiting A549 lung cancer cell in vitro compared to free rutin. That's why rutin should be combined with PCL nanofibers collagen. Therefore, this drug encapsulated nanofibers could offer a safe and effective way to reduce the risk of lung cancer recurrence after surgery. This data suggests that routine-loaded nanofibers could potentially have an positive impact in cancer treatment by increasing cells death, apoptosis in the cancer cells, and treatment of them. Thank you for listening. Do you have any question?
Thank you, Dr. Selman Saleh. That was an excellent presentation. So, any questions for Dr. Selman?
References. So usually the arsenic cell carcinoma are usually found in the salivary gland as well as the pancreas. So even though it has been reported in the literature around 64 cases, it's a very rare type of malignancy that affect the breast. Usually this type of cancer are triple negative, and the triple negative breast cancers usually have a bad prognosis with the early recurrence and metastasis. But this type of cancer, arsenic cell carcinoma, it is a triple negative cancer, but it has got good prognosis. However, six cases has been reported with metastasis out of 64. And going to clinical discussion, our case, she's a 78-year-old lady presented to breast clinic following a screening mammogram. And on clinical examination, there was a 3-centimeter lump in her right breast in the upper outer quadrant with no features of skin or chest wall fixity. And her axilla was normal. And going to history, there was no breast symptoms. She couldn't feel the lump. And her previous screening mammogram was normal. And there was some loss of weight and fractures of shoulder and hip, which is not related to breast cancer. and she was on some statins, painkillers, and inhalers. And going to the investigation, after her screening mammogram and ultrasound, it showed 30 millimeter M3U3 lesion in the right breast upper outer quadrants. So M3U3 lesion means that is like a probably benign one, and the mammogram or ultrasound didn't mention there's a chance it could be malignant. And she had a biopsy on the area as well. And we discussed in our MDT, and the plan was for MRI scan of both breasts, because this type of cancer could be mammographically occult. And the MRI shows an enhancing lesion nearly 69 millimeter. That's actually double size of the lesion that we found in the mammogram, which involving the right breast in the entire upper quadrant. And she subsequently had staging CT to look for any possible chance of metastasis, and it was normal. And the biopsy showed unusual finding of arsenic cell carcinoma, which was grade 2 inversive type of cancer, and which was negative for estrogen, progesterone, and HER2 receptor. And again, we discussed in our MDT with the oncologist as well, because this type of this triple negative cancer of this size, she usually receive neoadjuvant chemotherapy. But considering her age and comorbid condition, an oncologist and the patient decided not to go ahead with the neoadjuvant chemotherapy. That would definitely give risk rather than benefit. And we decided to have a right mastectomy as patient wishes, and she had a central lymph node biopsy as well. And the pathology showed around 70 millimeter arsenic cell carcinoma, which is triple negative, and the lymph nodes were normal. And she further received adjuvant radiotherapy to the chest wall. And we followed up the patient with the annual surveillance mammogram like any other cancer, accompanied with clinical assessment as well. And after 24 months, she came to the breast symptomatic clinic with a diffuse erythematous lesion, which is involving the right mastectomy scar and at the upper abdomen, and I did a skin punch biopsy. Unfortunately, it shows diffuse large B-cell lymphoma over the chest wall. And her staging CT shows metastasis to small bowel, peritoneum, and possibly to liver. And at the moment, she didn't have any biopsy from the metastatic site because she was not going to be offered any chemotherapy. So at the moment, we don't know whether the secondary is from breast cancer or lymphoma. She was offered only palliative therapy. And if we go into the review of literature, the first case of primary arsenic cell carcinoma of the breast was reported in 1996 by Ron Caroli. And to date, 64 cases has been reported. This is going to be 65th case, and I'll be publishing this soon. According to previous reports, the age of onset is 23 to 80. And there was one lady from Japan who had a primary arsenic cell carcinoma at the age of 80, and our patient is 78. And the tumor size is varied between 10 to 55 millimeter. In our cases, it's a bit higher level, like 70 millimeter. And there was one reported case of male arsenic cell carcinoma and one other case of arsenic cell carcinoma associated with BRCA and P53 mutation. That cancer was multifocal with a poor or partial response to neoadjuvant chemotherapy, and that patient developed recurrence and metastasis to leptomeningeal brain and lung. And most of the arsenic cell carcinoma was triple negative. That means negative for estrogen, progesterone, and HER2. But one reported case was as estrogen receptor positive. But I couldn't find the reliability of that report, and they didn't mention how strong was the estrogen receptor. And this graph shows the follow-up. So out of 64, 36 patients were followed up for 24 to 36 months. 28 patients didn't have any recurrence or metastasis. Out of 8, actually 6 has metastasis, or 6 to 8 has recurrence. And most common metastatic area was bone, lung, liver, and brain. And 3 of them passed away with 12, 32, and 34 months following the diagnosis. And conclusion, the primary acidic cell carcinoma can be asymptomatic. In our case, patient couldn't feel the lump, and it can be occult in routine imaging like mammogram or ultrasound, which warrant further investigations like MRI scan of the breast. And if you're coming to the diagnostic criteria, it has got a distinctive molecular signatures or immunohistochemical expressions, which include CD56, CD117, DOG1, S100. This is how we diagnose primary acidic cell carcinoma from the biopsy. And this could be targeted therapy in the future. There is no targeted therapy available so far. This could be an area of further research. Thank you all. Any questions?
Thank you, Dr. Nidhi, for an excellent presentation. So I hope participants have learned and benefited by sharing your views.
The surface of the iceberg. As the method of novel, I don't expect that everything would be understood for the first time. You may need to get back to the related published articles which introduce and explain this method. In the next few minutes, let me give you some context of the problem solved here. The information here may be a bit subjective, but its purpose to just give you a context. So first of all, why do we need a method for finding non-infectious diseases? There are at least few next reasons. Unknown pathology of many non-infectious diseases. Large number of research exists, but there is no definite conclusion what causing many non-infectious diseases. Only about breast cancer, it's estimated there are hundreds of thousands of research available, but obviously breast cancer for majority of folks unknown what's causing it. Huge discovery time for non-infectious diseases causes, as in some cases, when knowledge is not complete. Any significant progress in discovery of non-infectious disease causes has happened after many years of research and often by luck. We still don't understand entirely multiple sclerosis, for example, Alzheimer, etc. There are many non-infectious diseases which pathology is still unknown. For example, stiff person disease, Crohn's disease, etc. There are also other reasons, obviously, for this method as well. So what are our challenges in creating such a method? First of all, of course, complexity of human biology, and importantly, perceived complexity that creates impression that it's almost impossible to understand it entirely. Second reason is, in our reason, is absence of effective truth criteria for researchers. We often have to rely on voting by experts on some kind of meta-analysis required to conclude that it's true or not. And our reason is also always is absence of effective. I'm sorry, let me roll back a little bit. So there is also a lack of special expertise due to traditional medical education, which prevents understanding of complete biological systems, despite the fact that our scientists already have means to manage complexity. Of course, there are other reasons. However, the method address some of the needs for that method and some of the challenges it's creating. Method requires small number of selected studies which already exist. It's often around 40 selected studies sufficient to make a conclusion of disease pathology. Evelyn, can you hear me okay? Just want to make sure. Okay. Method is used in existing research to solve question of pathology with high precision, which can be improved by adding to analysis more research. Method allows a short discovery time for non-infectious disease pathology, and due to this, allows to uncover disease pathology for many non-infectious diseases in months, not years. Method applies simple mathematically based laws to complexity of human biology. Method is using complexity of human biology to its advantage, not vice versa. Method allows to computerize the discovery of non-infectious disease pathology as it's based on algorithm which mathematically derived. The future computer application may require to enter a list of certain research as input and will give you an answer what are disease causes. Multiple level challenges can be addressed with this method. Now, let me move to the next slide, please. So now let's take a look at foundation of this method. The method has been created using a model presented in published article, connection between factors, you can see here, and disease frequencies, its application finding disease causes. This model, which confirmed empirically, is introducing two important relationships. A, between disease frequency and the number of physiological changes which are causing it. B, it introduced relationship between non-infectious disease risk due to some factor and the number of disease-causing physiological changes which created by the factor. As this method is using concept of precise science, we would call this as two laws. So using this concept, we proceed. So first law is law of disease frequency. It states that a non-infectious disease frequency, we use in this case incident rate, in population is determined by a number of physiological changes which causing this disease. The more the incident rate, the less the number of physiological changes which are causing it. You can see it here. This is the first law. The second law of disease risk, which states that a risk of non-infectious disease under the action of particular factor is determined by a number of disease-causing physiological changes the factor creates. The more the disease risk from this factor, the more physiological changes are created by this factor. Application of the first law of disease frequency has shown that practically all non-infectious diseases are caused by unique combination of 2 to 6 physiological changes beyond 1 sigma coexisting at the same time. I stress beyond, changes should be beyond 1 sigma, not just regular changes. Changes should be beyond 1 sigma in order to cause non-infectious disease. And physiological changes should be a combination of multiple changes coexisting at the same time. So usually Aristate required at least 2 physiological changes to cause non-infectious disease. Now let me move to next slide. The second law allows us to deduce disease causation criteria, which you can see on the screen. If we take risk factor as K, we calculated like OR -1 or relative risk -1. In this case, we can have a couple of disease causation criteria. First criteria is that a risk factor is a disease causation factor when it changes one physiological parameter beyond approximately 1 sigma interval. If K value for this is 3.55, and we take interval plus minus 50%. So in this case, if calculated K is within this interval, when the disease risk factor is disease causation factor. It's not, I stress, it's not simply a risk factor. It's considered disease causation factor. But it cannot obviously cause the disease as standalone. I stress that. Second criteria is that the risk factor is disease causation factor, which changes two physiological parameters beyond 1 sigma if K value for this is 19.67 plus minus 50%. There are also disease criteria for which changes 3 or more physiological changes, but where are used less often and can be found in article published regarding these studies. It's important to know that disease causing factors act by changing a set of physiological parameters approximately beyond 1 sigma interval, as I stressed before. In the below, you can see a frequency of factors which are causing disease, and can notice that the majority of disease-causing factors are changing only one physiological parameter. Knowing already that non-infectious disease requires at least 2 physiological changes, as I said before, beyond 1 sigma, of course, we can see that such a factor, for example, this one, cannot cause the disease as standalone. Our disease-causing factor needs to be there to change additional disease-causing physiological changes beyond 1 sigma in the right direction. Let me switch the page. Knowing two laws above, a disease causation factor, a disease causation criteria, and experimental data, we can now explain the direct mechanism of non-infectious disease pathology at higher level. On the diagram, you can see example of non-infectious disease pathology for disease with 2 physiological causes. Disease-causing factors are affecting multiple physiological parameters of human body. They make disease-causing physiological changes by impacting set of physiological parameters, so those go beyond approximately 1 sigma. So you can see here that factor 1 and factor 2 impacting same physiological parameter on the top. And you can see here factor 3 and factor 4 causing change beyond 1 sigma to physiological parameter 2. And this is happening for disease with 2 causes, despite the fact that those factors also changing other parameters. We're changing only these 2 parameters which are critical for disease to start, to get triggered. Only those 2 physiological parameters are important to trigger that disease, but disease with 2 physiological changes. Let me quickly shift gear. We have a lot of material to cover and have almost no time left. So I want to mention that process of non-infectious disease pathology for disease can be illustrated with padlock analogy. For disease with 4 physiological changes, we can see next padlock with 4 wheels. Each wheel represents a disease-causing physiological parameter for some specific non-infectious disease. On the left side, the padlock is closed, and it means the disease doesn't exist. The body is healthy. Now we can see if you can open one wheel of this padlock, which means some factor is changing in physiological parameter beyond sigma in the right direction. So you can see multiple wheels like that. Now, if you can open one wheel on this padlock, then nothing's going to happen because the padlock is going to be closed. If 3 other wheels getting open, then the padlock is getting open and the disease starts. So in other words, in order to start the disease in this analogy, you need to open 4 wheels, move 4 physiological changes beyond 1 sigma. This will make that lock open. And that's how disease, non-infectious disease, generically is getting triggered. That's based on the laws, 2 laws, which I already provided. Let me switch to another slide. So let's move to a section so we understand what to expect as a result of the method. First of all, we expect number of causes, number of physiological causes which trigger an infectious disease under investigation. Second of all, we expecting to get a factor causing disease, a list of found disease causing factors. For example, disease X is one of causes for an infectious disease, etc. Factor force, number of physiological changes which every disease causing factor is creating. Physiological causes, a unique list of physiological changes which are causing an infectious disease under investigation if all these changes are approximately beyond 1 sigma interval and coexist long enough. Number 5, factor physiological impact. We're expecting a table of factors which are causing the disease and their connection to all disease-causing physiological changes they create. Number 6, factor combinations, a table of factors which shows how to create multiple combinations out of them, so it must cause non-infectious disease if coexist long enough. It's not optional in that case. So also we get expectation what we're going to get hypothesis, a strong hypothesis of disease pathology for non-infectious disease under investigation. Number 8, what we expect supporting evidence. Available research, usually available to support physiological changes found to be disease causes for non-infectious disease under investigation. As a result of the method findings, we can find such a research to confirm the results. Prophylactic measures. So we can find, based on result of the method, ability to introduce prophylactic measures by knowing the disease causation factors and physiological changes. Treatment, cure ways, ability to introduce medication which treat, cure non-infectious disease under investigation due to known causes, detailed enough to effectively affect them with medication. Now, let me quickly discuss method actions, and I will move due to short time left. I move to results of its application. So let's take a look at the diagram describing how method works. We have a set of experimental data and algorithm which method is using to process this data. Data consists of few different groups. First group is group of data on incidence rate of disease. Second group is multiple research about the risk of specific non-infectious disease. For example, different studies on the risk of breast cancer. Third group is data on physiological changes observed in the presence of different risk factors for disease. Algorithm consists of few main steps, which include first law, criteria based on the second law, mechanism of mathematical match using tables, validation and post-processing of preliminary results, creation of factor, physiological changes, dependencies, creation of disease-causing factor combinations. You can see it here. As I said, a lot of material to cover, so unfortunately I have to run through this very quickly, but material is going to be available later on for your study. Now, algorithm consists of few main steps. As I said, a couple of laws which we already presented, and a couple of matching mechanism and validation mechanism. Okay. As we can see from a diagram, first step is usually determination of number of disease-causing physiological changes which are causing the disease using the law of disease frequency. So we're passing our incident rate through law of disease frequency, we get number of physiological changes. During second step, we determine a set of disease-causing factors by passing available data on disease risk factor for disease causation criteria. You can see here, we take disease risk factors, passing them through disease causation criteria which we presented, we're getting disease causation factors. The found disease causation factor often used to list all physiological changes observed in their presence and also execute a match for physiological changes across each of disease-causing factors using the specially populated tables. You can see this mechanism here. Once a match has been executed, it will give you a list of potential physiological parameters which are causing the disease. Preliminary matrix PM. This is the preliminary matrix PM is when corrected, adjusted using number of physiological changes found and hard condition found in disease causation criteria. The corrected adjusted list is when creating final list of disease causation factors. Okay, so I'm run out of time, so let me quickly move to example of the method so we can cover at least something in basics. So here's the example of first step for disease of 80 cases per 1,000 people. We get the number of disease causes number 2. So it's 2 physiological changes causing that disease. And number 2, we can see example how we calculating the how we decide based on the criteria if that risk factor is disease causing factor or not. So study shows for social phobia was associated with 5.7-fold increased risk of developing disorder. Taking OR equal 5.7, we see it's within range 4.5 plus minus 50%. This is criteria already transferred to OR, and I discussed before regarding K. So based on this criteria, it means in this case, social phobia is causation factor for disorder and impacting physiological parameter. So I want to stress 5.7-fold increased risk signify this is a disease causation factor. Why? Because it falls within this range based on disease criteria derived from first second law. Now, physiological changes for disease causation factor social phobia, we determine based on that physiological parameters which changing by this. So in this example, according to one study, a stress by social conjugation is able to cause a decrease in BDNF level. And like I described before, at the end, we're looking for matrix PM. So we get results. Matrix PM at the end shows which physiological changes are causing the disease. So in this case, on this hypothetical disease, we can see a reduction of GABA-energic inhibition and low BDNF causing the disease. Now, due to lack of time, let me switch to results of breast cancer, and we conclude with that. So application of explained about method of finding non-infectious diseases causes to experimental data show that the breast cancer physiology caused by breast cancer pathology is caused by 4 physiological changes beyond 1 sigma interval taking place at the same time. As you can see, breast cancer is caused by combination of next changes. So one of the change, increased DNA strand breaks beyond 1 sigma. They should coexist with TNF alpha increased beyond 1 sigma. Leptin level should be increased beyond 1 sigma. Estradiol level increased beyond 1 sigma. What this means basically, what particular woman will get a breast cancer after some time if she continuously has increased DNA strand breaks and TNF alpha increase beyond 1 sigma, and leptin level increase beyond 1 sigma, and estradiol level increase beyond 1 sigma. Trigger of breast cancer is condition satisfied long enough is a must, not optional. And we can see also here the connection between factors which shown here. So, for example, TNF alpha increase in this table, you can see it on the top, as long as our physiological changes. TNF alpha increase can be caused by such factors as being premenopause woman with BMI high 26.65 is going to be connected to TNF alpha increase. And also, if a woman has a cystic breast disease, it's going to have impact on increase of TNF alpha. So this table shows you a connection between physiological changes for breast cancer and factors which impacting those physiological changes. So in our example, quickly, I'm sorry for taking too much time, but a lot of materials. Low total carotene impact increased DNA strand breaks as long as BRCA, BRCA2 genes, which impacting also DNA strand breaks. So I want to stress here that it's not BRCA, BRCA2 genes by itself, but by impacting increased DNA strand breaks, as long as low total carotene doing the same. That's why breast cancer is getting triggered. Now let me quickly show another table. On this table, we show combinations of factors which causing breast cancer. So in the header, you see those same set of physiological changes: increased DNA strand breaks, TNF alpha increased, estradiol increased, leptin level increased, obviously beyond 1 sigma. In the columns, we can see the factors which impacting every physiological parameter. In order to find out how that specific case of breast cancer has been created, we need to pick one factor from each column. For example, if you choose low total carotene in a patient or future patient, if you say cystic breast disease, let's say high breast density and postmenopause, they increase BMI more than 31.1. So after some time, that woman must get breast cancer. It's not optional. That's how the table works. Now, quickly, Evangeline, I have a couple more minutes, right? Okay, so let me explain this diagram. So this diagram basically shows how the breast cancer has been created. So in here, you can see increased DNA strand breaks, TNF alpha increased, estradiol increased, leptin increased. So breast cancer is getting triggered if, let's say, total carotene impacting increased DNA strand breaks, or that future patient has a BRCA, BRCA2 gene, which impacts the DNA strand breaks. So either one of those factors is existing, we turn one wheel of that lock, which I showed you before. Now, if cystic breast disease is taking place, it's causing TNF alpha increase, or if that's a woman, premenopause woman with BMI high 26.65, this is causing TNF alpha increase as well. And same way, other factors causing the change. Once these all factors moved beyond 1 sigma, causation of breast cancer is not optional, it's a must. That person is going to get a breast cancer. Now, one more thing. In majority of cases, you can see the factor only impacting one physiological change, like in the example of BRCA1, BRCA2 genes, or total carotene. In this case, at the bottom, woman over 50 with low fat intake but alcohol consumption over 24 grams per day is impacting two factors. It's kind of rare, but it's possible. Estradiol increase and leptin level increase. That's why the risk of this factor approximately 18 times more, are approximately 18. That's a huge risk factor for alcohol consumption. Now, let me quickly show how we use these physiological changes to derive a hypothesis. So on this diagram, We have leptin increase, estradiol increase, TNF-alpha increase, increased DNA strand breaks. In this case, we just displaying them because we already found based on the method. Now, we build hypotheses by connecting those physiological changes using our knowledge of physiology, using our knowledge of immunology and other medical science. So in this case, connection is informally shown as impact from leptin is on increased number of DNA strand breaks through energy reduction. Estradiol increase impact increased number of DNA strand breaks because it's causing adducts in the DNA. And the TNF-alpha increase connected to increased DNA strand breaks because reduction of DNA restoration. And now, as a result, if you connect this breast cancer pathology hypothesis, of course, it's not a single gap hypothesis. You can build something if you find other ways to connect those factors. It sounds like this. An increased BO1 sigma, a number of DNA strand breaks caused by such factor as low total keratin. Why? Because we determined those factors causing the change. Cannot be repaired to increased BO1 sigma TNF-alpha level caused by cystic breast disease, for example, and increased BO1 sigma level of leptin caused by postmenopause woman weight increase. For example, there are other examples where leptin level increase reduce energy capability of breast cell in repair process, and along with additional level of DNA mutations due to adducts created by high estradiol level BO1 sigma deprive the breast cell from DNA repair capabilities required to compensate a stress for normal DNA degradation process, and DNA damages and mutations accumulate beyond control. This results in triggering of breast cancer. In other words, in short, the breast cancer is caused because there is a disruption of DNA damage and repair homeostasis that leads to breast cancer. And this probably can be applicable to other type of cancer as well. So one thing I want to mention here about practical application. So early diagnostics, instead of relying on a mammogram, which usually only indicates breast cancer, which already started, we can verify patients' all physiological changes regularly. And once we add 4 beyond 1 sigma, we can diagnose breast cancer beginning. At this point of time, mammogram will likely show no cancer yet. Prevention, control of physiology. Breast cancer can be prevented if you keep some of those 4 discovered physiological changes which within approximately 1 sigma range. Keep all within the risk range. Within this range is desirable. Prevention, control of harmful factor. The risk factors of breast cancer can be significantly reduced if you prevent the impact of all known combination of disease-causing factors. Of course, there can be some unknown or newly introduced factors, for example, some new chemicals in the household. Cure if breast cancer just started, when there is a chance that moving all physiological changes within 1 sigma interval via a group of medication which address all disease-causing physiological changes can reverse the disease at least in the early stages, or will create a favorable condition for further cure with other means. Pharmacological efficiency. Instead of creating brand new medication, we can combine existing medication together if there is no side effects of such combination, of course, to produce new medication or create medication protocol consisting of a known medication to create to treat or cure breast cancer. Understanding cancer pathology. And there are other, of course, useful things, but due to short time, I have to move quickly to this page and conclude this presentation. I'm sorry for taking so much time. So now, as we discuss a method of finding disease causes by experiments, we proposing to use a simple principle which can be observed in physiological process, which states, when regulating its own homeostasis, a separate physiological system of the body are indifferent to the side effects of this regulation. We can call this principle of indifference. We can observe this principle in multiple cases. For example, if I just give you one example, if brain needs to increase the blood pressure to improve supply of nutrients, oxygen, it's indifferent. I stress it's indifferent to the fact but heart may not be able to sustain this high blood pressure. Let me move to the next page for the sake of time. So, as a summary, laws of non-infectious disease. We introduced those laws, foundation of a method and mathematical model confirmed by empirical data, which has introduced lower disease frequency, lower disease risk. Physiological combination as a cause. A novel method of finding non-infectious disease allows to find disease cause as unique combination, as unique combination of physiological changes and also a variety of different combinations of factors causing those unique physiological changes. I stress there is only one unique combination which causes special non-infectious disease and in this case also cancer. But there are multiple factor combinations which can be found from the table which I show you, which causing breast cancer. We also found pathology hypothesis that allows to build strong hypothesis of non-infectious disease. Diagnostic, prevention, cure of diseases method open new possibilities in non-infectious disease, diagnostics, prevention, cure, development of new medication using experience of disease. Fortunate country I didn't cover, but that's also the case to improve experience of disease. Unfortunate countries. We had a lot of things to cover, so I missed that piece, but you can go over it yourself. Principle of indifference we just covered. Breast cancer causes, one more time, combination of next physiological changes which coexist at the same time long enough. It's causing breast cancer. It's a must if you the individual has those increased DNA strand breaks above 1 sigma, estradiol increase above 1 sigma approximately, above 1 sigma, TNF alpha increase above 1 sigma, leptin level increase 1 sigma. Breast cancer hypothesis we discussed at high level, and I repeat, a disruption of DNA damage and repair homeostasis leads to breast cancer at high level, and low description you observed before. Medicine is a precise science. Method application helps to move medicine on the path of becoming precise science by allowing to apply mathematically precise algorithm and conclusions. This approach taken can be called like analytical medicine, which can use experimental data and make precise conclusion, not dots, using mathematical methods about pathology of non-infectious disease, as I hope has been demonstrated here. For further study, you can find published research regarding connection between factor causing disease frequencies, method of finding non-infectious disease, and for breast cancer application can be found in 2 articles at least. Evangeline? Any questions?
Thank you, Dr. Allen. That was an excellent presentation. So, are there any questions for Dr. Allen Olin?
En este caso en ratas, sí, donde empleamos un extracto, específicamente es un extracto vegetal de una especie llamada Centrus echinatus, el mismo que de manera tradicional se venía empleando por ciertas comunidades un poco alejadas, ¿no? De zonas muy alejadas en Perú, pero de que no se tenía mucho conocimiento de su empleo a nivel más, digamos, más científico. Entonces, eso fue lo que nos impulsó posiblemente a evaluar cuáles eran las propiedades que tenía este producto natural. Lógicamente tenía que ser adecuado a un modelo farmacológico, ¿no? Este producto natural es una hierba. Algunos lo consideran como una hierba mala porque en este caso crece de repente dificultando el crecimiento de los en cultivos, ¿no? Asimismo, también suele utilizarse como forraje para ciertos animales y en algunos casos también suele ser un poco dañino cuando se consume en elevadas concentraciones, ¿no? Este producto vegetal fue obtenido específicamente de una localidad en La Libertad, en Perú, ¿no? Este producto, digamos, se utilizó de manera completa, ¿no? Debido a que, digamos, al ser un arbusto, es un poco complicado poder retirar o separar sus partes como son las flores, como son las hojas o raíces, ¿no? Además, este producto Centrus echinatus, más conocido como cadillo, tiene ciertas protuberancias que, digamos, dañan en este caso a las personas, ¿no? Se incrustan en la piel, entonces causan mucha dificultad en los cultivos. Pero haciendo un análisis fitoquímico, encontramos un elevado contenido de metabolitos, sobre todo flavonoides, compuestos fenólicos, alcaloides. Entonces, este elevado contenido es que nos hizo de repente proponerlo con una, en este caso, que tenía una posible actividad a nivel antioxidante y a nivel anticancerígeno, ¿no? Para esto hicimos un diseño. Primero, lógicamente, al ser un producto natural, no tenemos estudios de seguridad, ¿no? Por lo tanto, era indispensable poder evaluar una dosis letal 50 en 84 ratones a diferentes dosis, ¿sí? Para poder determinar o para poder perfilar algunas posibles dosis, ¿no? Y lógicamente las dosis que apliquemos no sean dañinas en este caso para aquellas personas que lo consumen, y mucho menos si vamos a establecer un modelo farmacológico, no dañe en este caso o cause la muerte de los animales de experimentación. Los tratamientos se aplicaron desde una dosis mínima hasta 20.000 miligramos por kilogramo peso, ¿no? Entonces, y se observaron en este caso el comportamiento de los animales de experimentación, las muertes de los ratones, ¿no? Durante 14 días, de acuerdo a lo que exige la literatura. Asimismo, existen tratamientos con plantas medicinales, ¿no? Que son empleados por un tiempo más amplio, ¿no? Hablamos de una toxicidad crónica o una subcrónica, de acuerdo a la OCDE, correcto, donde utilizamos 20 ratas, machos y hembras, en este caso para evaluar toxicidad oral a dosis repetidas. Y finalmente, lo que evaluamos, ya teniendo estos datos, nos propusimos ciertas concentraciones y evaluamos ya el efecto protector de este extracto, ¿no? En ratas albinas. De acuerdo a los procedimientos que hemos seguido primero para la obtención del extracto, el extracto, en ese caso, primero se recolectó la planta, es en una localidad o un pueblo llamado de Santiago de Cao en La Libertad, en Perú. Las mismas se recopilaron pues de manera completa, fueron secadas, ¿correcto? Fueron trituradas y luego se realizó un extracto etanólico, ¿no? Este extracto etanólico consiste pues en la pulverización de las plantas, agregarle etanol, lógicamente de manera previa hicimos tres tipos de extracto: un acuoso, un extracto etanólico, un extracto hidroalcohólico, para poder de repente dilucidar en cuál de ellas se encontraba la mayor cantidad de compuestos fenólicos, de flavonoides, que eran los principales metabolitos con características anticancerígenas, ¿no? Y encontramos que el extracto etanólico nos proporcionaba mayor cantidad de metabolitos debido a que este componente extrae tanto metabolitos polares y apolares, ¿no? De manera equitativa. Por lo tanto, una vez obtenido el extracto etanólico por maceración durante 7 días con etanol, sí, evaporamos el solvente y el residuo seco que nos quedó, este es el extracto puro, el cual nosotros preparamos ciertas diluciones para establecer nuestro diseño de experimentación. Lógicamente, este extracto, sí, se le hace un estudio, en este caso al producto vegetal, se le realizó un estudio fitoquímico, ¿no? Se le realizó una identificación taxonómica para corroborar, en este caso, el nombre científico. se le hizo un estudio, en este caso, para obtener el extracto y luego se realizaron ciertas diluciones. Nuestro diseño estuvo relacionado o estuvo basado en la formación de 5 grupos. Un primer grupo que contenía suero fisiológico, y en este caso sería el control. Un grupo 2, el inductor del cáncer, que es el dimetilbenzoantraceno, ¿no? El mismo que se administró por vía intraperitoneal 20 miligramos por kilogramo o 20 miligramos por rata, ¿no? Por vía intraperitoneal diluido en aceite de oliva. El grupo 3, 4 y 5 fueron los tratamientos. Lógicamente recibieron el dimetilbenzoantraceno y los tratamientos. El grupo 3 recibió el extracto, pero a baja concentración, 10 miligramos por kilogramo. El grupo 4, el extracto 100 miligramos por kilogramo. Y el grupo 5, el tóxico y el extracto 200 miligramos por kilogramo. Cabe recalcar que nosotros estamos evaluando un efecto protector. Por lo tanto, primero se administró, en este caso, el dimetilbenzoantraceno y de manera conjunta, por vía oral, se administraron los extractos. ¿Qué queríamos evaluar? Posiblemente la disminución del número de masas tumorales y la disminución del tamaño de las masas tumorales dependiendo los grupos. Aquí, dentro de los resultados que nosotros hemos encontrado, tenemos, por ejemplo, el screening fitoquímico. Este screening fitoquímico, si observamos, este producto, el extracto, contiene gran cantidad de taninos, compuestos fenólicos, alcaloides, sobre todo flavonoides, que son uno de los principales componentes que nosotros buscamos, lógicamente, para poder asociar el efecto anticancerígeno. Asimismo, también encontramos los aminoácidos libres presentes en este extracto. Lógicamente, con el screening fitoquímico, nosotros podríamos dilucidar múltiples usos de este extracto vegetal, ¿no? Para poder plantearnos posiblemente un efecto hipoglicemiante, ¿no? Posiblemente protector gástrico, o gastroprotector, entre otros, ¿no? En este caso, anticancerígeno. Aquí nosotros tenemos el resultado del estudio de la toxicidad oral, ¿no? Aguda, o también conocida como dosis letal 50. Como observamos, nosotros hemos aplicado hasta 20.000 miligramos por kilogramo de peso, ¿no? Para poder establecer la dosis letal 50. Actualmente ya se estipula que si dosis de 2.000 kilogramos, de 2.000 miligramos por kilogramo de peso, no causa daño, en este caso al espécimen, por lo tanto, se le considera una sustancia inocua. En este caso nosotros nos arriesgamos un poquito más y determinamos hasta 20 miligramos para poder establecer exactamente la dosis, y la dosis estaba en 16.222,84 miligramos por kilogramo. Ahora, ¿para qué nos sirve determinar una dosis letal 50? Esta nos permite poder encontrar la dosis efectiva media, ¿no? Y con esta dosis efectiva media nos aseguramos que los animales de experimentación no presenten toxicidad. Y por lo general, de manera práctica, este valor lo dividimos entre 10 y sería más o menos 1.622 miligramos por kilogramo, que es lo que no causaría daño al espécimen. O sea, dosis menores a 1.600 no le causarían daño al espécimen, por lo tanto nos permitiría poder evaluar múltiples dosis. Correcto. Pero tampoco podemos arriesgarnos de irnos al límite, porque también los extractos no solamente tienen un solo componente activo, sino son una mezcla de componentes activos. Por lo tanto, de manera asociada, podrían generar reacciones adversas. Y asimismo, dosis elevadas también podrían generar posibles reacciones adversas. Evaluando todo esto, es que nosotros de aquí nos planteamos de repente utilizar dosis adecuadas, ¿no? De máximo 200 miligramos por kilogramo de peso. Dentro de los resultados que nosotros encontramos al realizar la toxicidad oral a 45 días, ¿no? Encontramos pues de que la administración diaria de 200 miligramos por kilogramo de peso a ratas, tanto ratas hembras como ratas macho en este caso, ¿sí? No presentaron diferencias significativas. Incluso el extracto mantuvo dentro de los niveles normales, ¿sí? Tanto, por ejemplo, el colesterol dentro de niveles normales, a pesar que en este caso se administraron de manera continua. Por lo tanto, ahí tal vez podríamos avisorar que este producto también podría ser utilizado para mantener los niveles adecuados de colesterol, ¿no? Igualmente el HDL, triglicéridos. Miren la glucosa en este caso lo mantuvo, ¿no? Dentro de los parámetros normales, dentro de los 45 días. De la misma manera, ¿sí? Fosfatasa alcalina, transaminasas, urea, ¿no? Dentro de los parámetros adecuados. En este caso, la alimentación fue en este caso alimento balanceado, en este caso lo llamamos ratonina, es un alimento balanceado que nos aporta una entidad del Estado. Y lógicamente se controló los pesos tuvieron un crecimiento gradual conforme pasaba el tiempo. Y asimismo, también observamos dentro del paquete leucocitario que tanto estos cuerpos formes como abastonados, segmentados, eosinófilos, basófilos, monocitos, linfocitos y leucocitos se mantuvieron también dentro del parámetro normal, ¿no? Esto quiere decir que la administración de este producto a esta dosis específica evaluada, ¿sí? No alteraba los parámetros biológicos. Pero también existían o existen ciertos estudios donde estipulan que el consumo de estos productos también podría causar ciertas alteraciones en algunos órganos blandos, como el estómago, el vaso, el riñón, el hígado, el pulmón, el corazón y el cerebro. Siempre haciendo el control, siempre haciendo la comparación con el grupo control, encontramos pues de que no hubieron diferencias significativas, ¿no? De que pudieran abismar de repente una hepatomegalia, ¿no? Algún crecimiento excesivo de algún órgano. Y lógicamente esto también se vio dilucidado en un análisis anatomopatológico, ¿no? Acá en este caso solamente asociamos el peso comparado con el control, tanto en ratas hembras como en ratas machos. Eso nos permitió plantearnos las dosis. Ahora, el tratamiento con dimetilbenzoantraceno, ¿sí? Para poder generar o para poder observar las masas tumorales, se desarrolla dentro de los 4 meses, o hablamos de 16 semanas, en promedio para que aparezcan las masas tumorales. Entonces, desde el primer día que se indujo estas masas tumorales con el dimetilbenzoantraceno, ¿sí? Se le administró de manera asociada por vía oral los extractos. Lógicamente, es muy diferente tener un grupo que solamente recibe el extracto y en este caso los grupos que ya reciben el tóxico que es el dimetilbenzoantraceno. Se evaluó en este caso, cómo es que la administración continua del dimetilbenzoantraceno y del extracto iba a generar ciertas modificaciones de ciertos parámetros. Pero también nos dimos con la sorpresa que en este caso, esta sustancia extracto de Senchus echinatus cadillo mantuvo también los niveles normales a pesar de haber recibido el tóxico. De la misma manera, la fórmula leucocitaria, ¿no? Abastonados, enmetados, eosinófilos, entre otros, se mantuvieron también dentro de los parámetros normales, esto evaluado a la semana 16, ¿no? A la semana 16 del proceso anticancerígeno. ¿Qué encontramos ya en la semana número 16? Primero que las masas tumorales empezaron a observarse a las 4 semanas. Pequeñas masas tumorales, ya que de manera semanal hacíamos una revisión, una palpación de las zonas probables de la aparición de estas masas, siendo las más frecuentes la zona torácica, abdominal e inguinal, ¿no? Se hacía también la revisión de la coloración en este caso, del pelaje, los ojos, el comportamiento, las heces, ¿no? De repente habían heces acuosas, ¿no? Entonces, también se observó el crecimiento, ¿no? La ganancia de peso conforme iba pasando semana a semana. A la semana 16, una vez que hemos sacado la muestra sanguínea por vía intracardíaca para realizar lógicamente el perfil que acabamos de explicar, también contabilizamos el número total de masas tumorales. Ya aquí en este caso, por ejemplo, los grupos que solo recibieron el dimetilbenzoantraceno presentaron 23 masas tumorales a nivel torácico, siendo la zona donde más se observaron este crecimiento. Asimismo, en la zona abdominal fue un poco menor, ¿no? Obteniéndose 6 masas tumorales y en la zona inguinal 10 masas tumorales. Ojo, teniendo en cuenta que por cada grupo empleamos 10 animales de experimentación. Por lo tanto, lo que tenemos ahí es el promedio, ¿sí? El promedio, o disculpen, ahí tenemos en este caso las masas tumorales que se apreciaron el grupo completo, en el grupo completo, de 10 ratones, de 10 ratas en este caso. En el grupo de dimetilbenzoantraceno, cuando ya recibieron los extractos en diferentes concentraciones, encontramos una disminución gradual, ¿no? Del número de masas tumorales y del tamaño de las masas tumorales. Por lo tanto, de tener unas 39 masas tumorales con dimetilbenzoantraceno en el grupo que recibió el tóxico, fue disminuyendo, por ejemplo, con el extracto a 10 miligramos. Ya tenemos, por ejemplo, ahí unas 27 masas tumorales a 100 miligramos por kilogramo. Ya tenemos 14 masas tumorales. Y finalmente, con el extracto a 200 miligramos por kilogramo tenemos 9 masas tumorales. Esto traducido en porcentaje de inhibición o de protección, en este caso frente al cáncer de mama, hemos llegado a la conclusión que el dimetilbenzoantraceno presentó a 10 miligramos por kilogramo presentó un 30,76% de protección de masas tumorales, ¿no? A la vez también hemos encontrado que con 100 miligramos por kilogramo, 64,1% de protección o de prevención de masas tumorales, y con el dimetilbenzoantraceno más el extracto a 200 miligramos un 76,92%. Cabe recalcar de que no necesariamente esto o estos resultados, ¿no? Me asegurarían que en este caso, este extracto, pues, prevendría totalmente el cáncer de mama, sino nos genera una alternativa. Habría que explorar lógicamente otras posibilidades, tal vez un aislamiento del principio activo, en este caso flavonoides tal vez, porque aquí el efecto específico se debe a la sinergia de los metabolitos, ¿no? Asimismo, este es un modelo experimental que lógicamente requiere de más estudios de seguridad. Se requiere plantear posiblemente algunos métodos de extracción mucho más complejos. Hoy en día ya estamos empleando tal vez utilizar métodos de extracción por ultrasonido, ¿no? En este caso, lo que queremos asegurar y mantener son las propiedades de los metabolitos secundarios. Cuando realizamos el estudio ya anatomopatológico, ¿no? de ciertos grupos, encontramos, pues, por ejemplo, en el primer caso, en el grupo de solución suerofisiológico que fue el
Hello,
control.
Dr. Caesar. Sorry for interrupting your presentation. You're exceeding your timing.
Ok.
Yeah, please wind up
eh,
as soon as possible.
Sí, solamente para terminar con esto, por favor. Solamente encontramos, pues, que dentro del grupo que recibe dimetilbenzoantraceno se pudo observar cáncer o carcinomas intraductales y con los grupos experimentales se redujo de manera notoria y se observó una recuperación, en este caso de ciertas zonas, ¿no? Que habían tenido algún daño cancerígeno. Solamente para terminar, el extracto de cadillo se avisora como una posible alternativa para hacer estudios específicos, aislar ciertos metabolitos y ser probado con más estudio de seguridad, con más estudio de eficacia, ¿no? Y finalmente esto nos está conllevando a realizar ciertos trabajos, ya no utilizar solamente el cadillo, sino también asociaciones con ciertos productos o aceites o productos vegetales de Perú y poder avisorar cuál es ese posible fórmula o concentraciones de principios activos para poder mejorar la eficacia, lógicamente, en el cáncer de mama a nivel experimental. Muchas gracias.
Thank you so much for your presentation, Doctor. So any questions in regards to its presentation?
Ser en primera persona todos los avances y desafíos que tenemos como país para enfrentar esta patología. Entonces, vamos a sacar esto. Ahí. Los cambios epidemiológicos que ocurrieron en nuestro país a mediados de los 80, ¿cierto? Al final del siglo XX, mostraron un aumento de la morbilidad y mortalidad de las enfermedades no transmisibles. Dentro de ellas, actualmente el cáncer es la segunda causa de muerte en la población chilena y específicamente el cáncer de mama es la primera causa de muerte en la población femenina. Han pasado, ¿cierto? Durante 50 años se han hecho numerosas intervenciones en nuestro país que reflejan las ganas de poder llevar a cabo todo lo que la Organización Mundial de la Salud dicta para poder tener un programa de cáncer adecuado, para poder tener un tratamiento adecuado. Sin embargo, una serie de características propias de nuestro país que van mucho más allá de lo que es salud propiamente tal, generan una gran cantidad de desafíos que debemos tener real conciencia para poder implementar. ¿Qué características? Chile, para quienes no lo conocen, es una larga y angosta faja de tierra al sur de América del Sur. Estamos al sur del mundo. Tenemos una centralización muy grande en esta parte del país, en nuestra capital, en la región metropolitana, en Santiago, y en algunos polos de desarrollo, pero en general todo se concentra en Santiago, específicamente todo lo que tiene que ver con salud y avances de salud. La población en nuestro país es alrededor de 20 millones, somos un país pequeño, con un PIB nominal per cápita de $16.000 aproximadamente, con un coeficiente Gini de 0,43. Este indicador es un indicador muy importante porque nos habla de las diferencias que tenemos en nuestro país. Es un país que, independiente que se han hecho múltiples temas, múltiples desafíos, seguimos teniendo una gran desigualdad social. Tenemos también algo que complica mucho la vida, que es la multimorbilidad. Hoy en día nuestra población alcanza el 12% con polifarmacia, es decir, que toman más de 3 a 5 medicamentos por día. Esto es por la Encuesta Nacional de Salud. Eso sí, hemos tenido muchos avances en tecnología en salud y eso ha generado también mayores expectativas de lo que es el área salud. Hoy día la gente está pidiendo más, estamos viviendo más, por lo tanto, los tratamientos y todo lo que se hace debe ser acorde de lo que las personas necesitan. Nuestro sistema de salud está compuesto por dos áreas, el sistema público y el sistema privado. Ambos son regulados por el Ministerio de Salud, que es un ministerio que está centrado en el poder ejecutivo de nuestro país. Esta diferencia del sistema público y privado obedece un poco al coeficiente Gini. O sea, aquí se ve una gran desigualdad en las oportunidades de atención, en la calidad de la atención, la calidad de los medicamentos, de las terapias, que van generando, ¿cierto?, una desigualdad importante. En el sistema público se atienden alrededor del 70% de la población nacional y los niveles que prestan atención tienen que ver con hospitales y centros de salud familiar. El pago se hace a través del Fondo Nacional de Salud, que se genera con el 7% de todas las remuneraciones. El Estado recauda el 7% de todos los sueldos, de todo lo que nosotros cobramos al trabajar, y con eso se genera el Fondo Nacional de Salud. El sistema privado atiende más o menos al 28% de la población, y aquí está toda la red de clínicas privadas y centros médicos privados. Y el pago se hace a través de ISAPRES, que son instituciones de salud previsional. ¿Qué hacen ellas? Aparte del 7% de los trabajadores, cobra un poco más, bastante más, la verdad, y con eso genera programas de salud que son pseudo seguros de salud con los que uno puede atenderse en el sistema privado. ¿Cuáles son los problemas que tenemos en nuestro país? En general, va el largo tiempo en las listas de espera. 72% de nuestro país, y ese es un problema que se está debatiendo hoy en el Congreso. Tenemos una lista de espera enorme. 63%, un alto costo en salud. Y el 49% de las personas que se les preguntaron, faltan especialistas. Nosotros formamos pocos especialistas y el otro problema grande es que los especialistas se quedan en el centro de Chile, no van a las regiones, no van a los centros públicos, la mayoría se queda en el sistema privado. Fíjense que los gastos en salud, los gastos catastróficos, y el cáncer es una enfermedad catastrófica, el 60% de los chilenos creen que no podrían pagar por la atención que necesiten ante una enfermedad grave, el cáncer, obviamente, entre ellas. Porque el ingreso promedio de los cotizantes de FONASA es $700. Y el costo de una patología grave promedio es de $7.200. O sea, tendría que pagar 10 veces el sueldo promedio en Chile. Es muy alto el costo. También tenemos, debido a estas listas de espera y a la falta de especialistas, tenemos una detección muchas veces tardía del cáncer de mama, que hoy ha ido mejorando y en las próximas diapositivas les contaré por qué. Sabiendo lo importante que es el diagnóstico temprano, ¿cierto? La sobrevida que ya se ha visto en este congreso y en este webinar, lo importante que es el diagnóstico lo más temprano posible para la sobrevida de las pacientes. Chile tiene un problema importante con las estadísticas de esta enfermedad porque no habían buenos registros del sector público. Históricamente el cáncer de mama era el tercero. Primero estaba el cáncer gástrico, luego el cáncer de vesícula y finalmente el cáncer de mama. Hoy en día, desde el año 2009, el cáncer superó a estos dos cánceres, al cáncer de mama, al cáncer gástrico y al cáncer de vesícula. En los años 80, ¿cierto? Como lo dije en la introducción, cambiamos de un perfil que era bastante infeccioso, esas eran las patologías que en Chile predominaban, eran nuestros problemas hasta el año 80, la desnutrición también era muy fuerte. Cambiamos, ¿cierto? Con el desarrollo a este perfil que tiene que ver con enfermedades no transmisibles. La mortalidad, la tasa de mortalidad por cáncer está entre 12 a 13 por 100.000 mujeres de todas las edades. Y esto hizo que se cuestionara esto de no tener mamografía, el screening de mamografía en un programa nacional del cáncer. Hoy en día tenemos un programa nacional del cáncer que fue realizado o partió, se implementó el año 95. Los próximos años ya cumplimos 30 años con este programa que ha sido muy exitoso. En el 95, entonces, el Ministerio de Salud crea este Programa Nacional del Cáncer, que incluye, por supuesto, al cáncer de mama. Los objetivos importantes eran tener una detección temprana, un diagnóstico temprano y dar un tratamiento adecuado y lo más rápido posible. También se hizo un entrenamiento en el nivel secundario de los doctores y de las matronas para poder diagnosticar y derivar esta patología rápidamente. El diagnóstico, el screening de cáncer se hace en dos grandes etapas. Por la examinación física, ¿cierto? Nosotros somos mucho del autoexamen de mama y el examen de mama en todo control ginecológico, y la progresiva implementación del screening de mamografía en mujeres de 35 a 65 años. ¿Cuáles fueron las mejores estrategias? Establecer un adecuado registro bajo términos, aumentar la cobertura, ¿cierto?, del examen, y para esto, en el examen que se hace en las mujeres anualmente, al cumplir 35 años en la atención primaria de salud del sector público, se le indica una mamografía. Y esto hizo que el screening del cáncer en etapas tempranas 1 y 2 fuera del 50 al 70% de las mujeres que se atendían en el sector primario. En Chile la incidencia del cáncer ha ido aumentando alrededor de un 60% en 2 décadas. Pasamos de 28.9 en el 2000 a 40.9 por 100.000 mujeres en el año 2020. La mortalidad del cáncer en el año 2020 fue de 11.1%. De acuerdo con los datos del Ministerio de Salud, en Chile, 6 mujeres mueren diariamente por esta enfermedad. En el año 2023 existieron 2.263 muertes por cáncer de mama. Este es un número impresionante. También el tener esta casuística alta y los estudios y el programa permitió determinar factores de riesgo, ¿cierto? Y dentro de los factores de riesgo tenemos la edad. Hay un mayor porcentaje de mujeres con 50 años o más. Todo lo que tiene que ver con la parte reproductiva y los factores hormonales, ¿cierto? El desplazar los años para ser mamá, disminuir la lactancia materna, son considerados riesgos. Y también tenemos un estilo de vida bastante sedentario, el alcohol, el consumo de alcohol y el incremento de la obesidad. La pandemia oculta. Bueno, y en esto entonces, con este programa y con todo lo que se ha estudiado, se empezó a detectar precozmente, dar mamografías gratis en el primer sistema, y también se creó un programa que se llamaba Auge en el principio y que hoy día quedó determinado como GES. Y esto también lo que permitió fue aumentar la cobertura en las áreas rurales o extremos del país. Designar centros en los extremos del país donde hay especialistas, donde hay gente capacitada, donde pueden llegar más rápidamente la gente que está alejada aún más, ¿ya? Entonces, ¿qué es el GES? El GES son las garantías explícitas de salud. Es decir, el gobierno, el Estado, el Ministerio de Salud, se compromete a garantizar una serie de de mecanismos por los cuales se da una igualdad en el tratamiento de las patologías que son más frecuentes y más costosas. Entonces, lo primero que dice es el acceso. Vamos a tener acceso, vamos a evitar estas largas listas de espera para que puedan tener una intervención, un diagnóstico de un cáncer de mama. La oportunidad de atención, y aquí es muy importante porque pone tiempos máximos en los cuales se debe resolver el problema. La protección financiera, que realmente es muy importante porque el cáncer es un problema familiar. Los costos son altísimos. Entonces, esta protección financiera hace que la gente que está en el sistema público de salud no pague nada y las personas que están en el sector privado paguen a lo más un 20% de las prestaciones. Y la calidad. También el Estado garantiza el beneficio de tener atenciones de calidad. Entonces, tenemos también que se ha avanzado en los tratamientos. La quimioterapia, por ejemplo, está siendo muy estudiada para ver diferentes drogas. La inmunoterapia, que hoy está siendo muy usada en los triple negativos, en los cánceres triple negativos, ¿cierto? Y en cirugía. La cirugía que antes era devastadora, porque para las mujeres las mamas son muy importantes, hoy en día hay una serie de técnicas que favorecen la reconstrucción, que favorecen determinar solamente una parte, una mastectomía parcial o una mastectomía total con reparación rápida. También en este programa se determina mucho trabajar con la comunidad, porque es algo que hemos visto que la comunidad se siente partícipe y cuando ellos trabajan, hacen mucho mejor que nosotros en llegar como gente de salud, en llegar a la población en general. En el mes de octubre en Chile se determina el mes rosa, en el cual se hacen diferentes campañas, están mamografías gratis, se hacen ferias donde se enseña el autoexamen, donde se da a conocer los beneficios, la mamografía, etc. También se hace mucha educación comunitaria, enseñando a comunidades de mujeres cómo determinar rápidamente si tiene un problema o no tiene un problema. Y tenemos asociaciones, organizaciones que son fundaciones que apoyan el trabajo en el cáncer de mama. Aquí vamos a ver, por ejemplo, las garantías que tenemos en Chile del cáncer de mama. El tiempo de espera para el diagnóstico, 45 días. Para la etapificación, otros 45 días. O sea, es muy rápido comparado con lo que teníamos antiguamente.
I'm sorry for interrupting your presentation, doctor. You're exceeding your presentation time limit.
Oh, bueno.
Yeah. Please wind up your presentation as soon as possible.
Ahora, solo esto. ¿Cuáles son los desafíos? Inequidad en el acceso, diagnóstico tardío, limitado el acceso a los tratamientos, lagunas en la información y todo lo que tiene que ver con tabúes en el cáncer. El cáncer es una enfermedad sistémica, holística, por lo tanto no lo puede abordar un solo profesional. Y en lo que estamos trabajando hoy es en el trabajo multidisciplinario, porque todos podemos ayudar. Y esta es mi hermana hoy, gracias a Dios, está en su segundo año y ya está en control del cáncer. Muchas gracias.
Thank you so much for the excellent presentation, Dr. Maria. Any questions from the audience side? If anybody is having any questions, please unmute yourself and raise the queries.
Thank you.